All right, so good morning, everyone, and happy Friday. So before we proceed with today's event, we would like to acknowledge that we are on the traditional homeland of many diverse First Nations, Métis, and Inuit people whose ancestors walked this land before us, and those persons who share this great land with us today. So good morning, my NSWOC and SWAN family. My name is Joshua Moralejo, the Ontario NSWOC Regional Director. I currently practice as a clinical nurse specialist for wound and ostomy care and a nurse specialized in wound, ostomy, and continence at University Health Network, Toronto Rehab Institute, Bickle Center. I would like to express my gratitude for joining us this morning in today's Ontario NSWOC Education Day. Similar to our November education event, today's Education Day is hosted nationally, and I would like to extend a warm welcome to our NSWOC and SWAN colleagues from different provinces and territories outside of Ontario. So we have an exciting day planned for you, and as a strong advocate for continued competence and ongoing learning, we have 3 education sessions focused on the tri-specialty of wound, ostomy, and continence that will be delivered to us by our nurse practitioner and NSWOC colleagues. And on the other end of the spectrum, as an advocate for the integral roles of NSWOCs and SWANs in healthcare, I have also invited some of our colleagues to share to us the crucial roles they play in acute care, long-term care, and transitional care or home care. What my hope today for us is that this event will make you feel empowered, inspired to continue the incredible work that you do and acknowledge the positive impact that you make to our complex patient or client population that we serve, as well as the health systems that we are a part of. At the end of this session, you will receive a certificate of attendance and continuous learning hours that you can utilize for my NSWOC colleagues for their CNA renewal, as well as a survey that we would like you to also complete. So that is the entire day for us today. So we have a jam-packed session. But before we begin, I would like to formally thank our sponsors for today. I want to thank Mölnlycke and Convatec for their sponsorship that will support some of our NSWOC Canada initiatives to date. Now, at this time, I'd like to introduce our first speaker this morning, and I'm actually just going to stop sharing my screen over here so that Deborah can actually begin her sharing of a slide. So Deborah Mings has been in the nursing profession for many years, for 43 years, and she has had a diploma in nursing and a master's in healthcare practice and completed the IIWCC. Nursing has allowed Deborah to explore several clinical areas, including oncology, complex care, neurosurgery, and even labor and delivery. Deborah is most passionate about wound care and the prevention of pressure injuries. Deborah is semi-retired as a clinical manager and nurse practitioner working in skin and wound and ostomy. She is currently working part-time to support the corporate objective of preventing pressure injuries at Hamilton Health Sciences. So at this time, without further ado, I'm going to pass it on to Deborah Mings. Over to you, Deborah.
Good morning, everybody. It is a pleasure for me to be here, and I will just take a second to pull up my presentation. All right, I hope everybody can see that. As Josh mentioned, I have been in nursing a very, very long time, and so have had some great opportunities as a nurse. And so one of the big opportunities of my career has been working in skin and wound care. And I have to say, it has been the most fun, the most challenging, and has presented me the greatest opportunities. And so as NSWOCs and SWANs, embrace the sort of the fun aspect of doing this job and the challenge that you get from it, and the brain power that you have to use in order to figure out what's going on with your patients, because it is extremely rewarding. And I know I'm talking to the converted here, but my plug for this morning. So, you know, it's a great career to be in wound care, ostomy care, and continence care. So thanks for inviting me this morning. So I have a great passion, as Josh mentioned, for pressure injury prevention. If we can prevent pressure injuries from occurring, we can stop a lot of the disability and the issues that occur after pressure injuries occur. And so just today, I'm going to identify the prevalence and incidence of pressure injuries in the acute care sector, I want to talk about the role of hospital harm and never events in really trying to spotlight the importance of preventing hospital-acquired pressure injuries. And I want to talk about the strategies that we used at Hamilton Health Sciences. Oops. And I'm going to stop sharing here because, of course, my screen is frozen. And I'm just going to go back to sharing again and seeing what the problem is. Okay. We practiced this, and of course, in the practice, everything went fine. And so now you go to do it here, and of course, it is a problem.
That's all good. We're all with you. Zoom always wants to be a bit finicky first thing in the morning.
It certainly does. And now my presentation has disappeared. So hang on one sec while I just sort this out.
Take your time, Deborah. So as Deborah is fixing the presentation, we actually have plenty of time this morning. So please kindly use the Q&A box for any questions or comments that you may have for Deborah, and we'll take it up at the end of her session. There will be plenty of opportunity to really review those questions, and your questions actually very insightful for us to really explore, and possibly your questions may also be a question of your other NSWOC and SWAN family colleagues. So please don't hold back and ask questions for us to take up at the end. And again, welcome to our attendees here. I'm seeing a lot of people signing up here from around Ontario, from London, even Saskatchewan from here, I'm looking at the screen as well. So somebody from New Brunswick is here, somebody from Ottawa. So we are having a lot of attendees from across the nation, which is great and exciting to see. And now I'm seeing here that Deborah's screen is up and running. And I'll pass it back to Deborah.
All right. You know, the thing is, and we all know this as nurses, never panic, right? Because it will all work out just fine. So let's get started here. Let's talk a little bit about the prevalence of pressures, and this is in acute care. And so pressure injuries are an issue across the globe. And so we are not the only we're not the only country that has issues with pressure injuries. I pulled up this particular study because I liked that when I'm looking at sort of prevalence studies, this was the only one that I found that actually talks about who's coming in on admission with pressure injuries, because I think it's really important that we identify those patients at the very beginning who are being admitted with pressure injuries. And so this study found that out of this cohort of 5,900 patients, that on admission about 2.6% were already coming in with pressure injuries. And so that's very important for us to identify upfront those patients. Who's at risk? Well, we know some of this already. Higher age, inability to move independently. This study highlighted mode of arrival. So the patients who are coming in from long-term care are actually more at risk. And so I thought that that was an interesting point in this study that I hadn't seen in other studies. Underweight patients for obvious reasons. And then, you know, sort of this absence of pressure injury risk assessment or skin assessment on admission is so important because, again, you want to identify the hospital-acquired pressure injuries. You don't want the patients who are coming in with pressure injuries who are already established to be then a part of the number of pressure injuries that you're looking at. So you need to know who's coming in, and you need to know who in your organization has developed a pressure injury, because those are hospital acquired and those are the ones that we are trying to prevent. Just a little bit of extra information here about in Europe, in Africa, and in Canada. Our last sort of comprehensive study was back in 2004. And I understand, somebody can correct me if I'm wrong, but I can understand that Wounds Canada is actually doing an up-to-date on the prevalence literature for Canada. Now, and I have a special spot in my heart for elderly patients because of their vulnerabilities. And so 15% of elderly patients will develop pressure injuries within the first week of hospitalization. So again, really establishing and understanding who's at risk, and then identifying those patients, seeing if they've come in with pressure ulcers or if they have monitoring that first week particularly to see the development of pressure injuries. For those in long-term care, pressure injuries are most likely to develop within the first 4 weeks. And so we have, you know, times of vulnerability that we need to be really watching our patients. And, you know, the mortality rates associated with pressure injuries are really significant for our older patients. So that preventative piece is so important. And this is just the sort of a busy slide, but basically it's talking about the burden of pressure injuries in Canada. The fact that, you know, we've got a 35% increase year over year of the reporting of pressure injuries. Now that's all stages of pressure injuries. And so, you know, despite all the work that we're doing, you know, our pressure injuries are increasing. And so, you know, why is that? You know, I think we can all sort of speculate on, you know, the vulnerability of our patients, our healthcare system, our nursing shortage. And so prevention then is even more important because we are seeing the numbers of patients. So I want to just talk for a second about never events and hospital harm, because this is sort of started off the hospital that I worked at. Actually, I've since actually fully retired from Hamilton Health Sciences. So I actually get to sleep in the mornings, which is one of the great things about being retired now. So hospital harm, though, really set off our journey around pressure injury prevention in the organization that I worked in. And it's defined as the rate of acute hospitalization with at least one occurrence of unintended harm during a hospital stay. And so, you know, hospital harm, it can be quite significant. In 22-23, 1 in 17 hospital stays. So one patient involved in at least one harmful event. So, you know, that's quite significant. So how often does it happen? As I said, 1 in 17 hospital stays have some sort of a harmful event. And so what are the most significant sort of hospital harm events? Well, healthcare and medications is the most, and that's, well, they say bed sores. We know proper terminology is pressure injuries and medications, infections like surgical site infections, procedure related, and then patient falls are accounting for the sort of the top things that can happen to patients when they're in the hospital. And so so it's really, never events have been identified not to blame and not to sort of imply blame, but really a call to action. When I started out in nursing many years ago, we were basically told that in the hospital that I started out, if you had 3 serious medication errors, you would be fired. And so guess what happened? People did not report their medication errors. They didn't report because they were worried, right? And so now we've got a better culture of reporting so that we have a call to action, so that when things do happen, we can look in and see what were the root causes, what can we do to improve things. And so this is really what the never events is about. There's 15 never events, and they range from things as serious as you know, a neonate being abducted from the NICU or the nursery, and the one that we focus on is number 9, which is the stage 3 or 4 pressure injuries. And these are stage 3 or 4 pressure injuries acquired after hospital admission, and they are deemed to never events. And as of January 2024, never events are voluntarily reported to the Ministry of Health, and that data then is shared every 2 years. Now, I mean, it would be more helpful, I think, to have this data shared earlier, but that's a system that we currently have. So the system that I worked in, Hamilton Health Science, it's a huge multi-site hospital, over 1,400 beds, 15,000 employees, multiple sites. And so we offer everything from cardiac and stroke, palliative care, NICU to like 25-week-old babies. So we really see everything from birth to death in the organization that I work in. And so this is the structure that we used. And again, this structure did not come about overnight, but this is really the structure that we used to help us to get to a point where we really understood what was going on with the hospital-acquired pressure injuries and put strategies in place to prevent them from occurring. So we developed a corporate structure that prevents pressure injury and sets goals and targets. And that corporate structure goes all the way up to our CEO. Our board is involved. And so that actually makes a huge difference to the ability to get things done in an organization where when you have that level of support. We actually then also used our documentation system to leverage pressure injury prevention and obtain data. And I'll talk about that in a minute. We use Epic, and so we were able to make some changes to really support that. Our organization also uses CQI, continuous quality improvement, and we use those tools all the way across the organization and into unit-based activities to really support our pressure injury prevention activities. And we were able to really create a collaboration with our educators and our interdisciplinary teams to translate knowledge to action. As NSWOCs and SWANs, you can't do all this work yourself. You need to use your expertise as the content expert, and you need to use the expertise of other people to translate knowledge so that the work gets done, because you can't do all of this work yourself. And then we also developed corporate-wide tools and resources to support frontline learning, and that was extremely helpful as well. And there's new technology that makes pressure injury prevention really very interesting, and I'll just briefly mention that at the end. So this is all the pieces that we put together to create our pressure injury prevention strategy. So I'm just going to talk about sort of this whole corporate piece for a second. So as I said, never events, we started working on never events in 2016 when they first came out from Health Quality Ontario. And what that meant for us is that we started to collect our data around these 15 never events, including pressure injuries. And we used our adverse reporting system. We use RL Solutions. You may have your own reporting system. And so we used our adverse events reporting system then to collect the information on deep tissue pressure injuries, unstageable, stage 3s, and stage 4 pressure injuries. And we do this on a monthly basis. And so this is really how we started to collect our data. We spent a lot of time trying to get our data sorted out, so we actually had good information, because that's so key when you're trying to really work on these type of initiatives. And our NSWOCs were actually the ones who were responsible for reporting these adverse events, because our NSWOC group is the group who sees deep tissue pressure injuries, our unstageable pressure injuries, our stage 3s and 4s, and are the accurate stagers. And so they're the ones who were doing the reporting on our pressure injuries. Now, as our staff nurse expertise has improved, they also started putting in pressure injury adverse events as well. And people became more comfortable with the reporting because it wasn't punitive. It's a part of our system to say, like, let's make sure that we understand and have an accurate accounting for what's going on with our pressure injuries. And as I mentioned, the data is correlated, reported right through our CEO and up to the executive level. And so they're monitoring what's going on with our pressure injuries. So there is an accountability there, and there's an expectation that there's also support to do this work. So one of the things that at a corporate level, they did was that they set some goals to help support the organization. And what's reported up is the 3s, 4s on unstageable pressure injuries, and then the deep tissue pressure injuries are followed to see whether or not they resolve or they convert to this unstageable stage 3 and 4. And you know, probably all of you have watched deep tissue pressure injuries, and some of them do resolve, but some of them go on, become unstageable, and then stage 3s. And so following through and seeing what happens with those is sort of an important piece of the reporting. And what was also very helpful was actually having a Braden scale dashboard. And it was created from Epic documentation. So this actually came from nursing documentation on admission on the Braden scale. And so that piece was very important, making sure that nurses understood the importance of the Braden scale how important it is to do it on admission, because that documentation was leading then to our Braden scale dashboard. And we also had then Braden on admission. And then we could follow Braden's during hospital stay on this dashboard, therapeutic surface use, and OT/RD referrals. Now, the information is only as good as what's put into the documentation, but I think the Braden information was pretty accurate, and so we did have this information available to us. And so this was some of the goal setting that we did. You know, we have a large organization, and so our hospital-acquired pressure injury occurrence, we were trying to keep it to under 14 a month. And so at the time, when I left the organization, we were down to about 10 a month, which is actually, you know, for an organization our size, with our critical care units, our cardiac units, our neurosurgery units, you know, there was progress being made. And so the other piece I want to just say is that we also noticed some seasonal fluctuations. So, you know, a lot of work has gone into this. And so, but we did have months where we actually saw our numbers go up, and it was sort of like, okay, so we put all these resources in for pressure injury prevention, but yet we've had months where our numbers have gone up. What's going on? Well, if you actually look at that within the context of what was going on in the organization, you can see that, you know, during that period of time, we were in a flu outbreak, or we were in a nursing shortage, or we had a bunch of really critical patients come in at the same time. And so understanding the context of what's going on in the organization is extremely helpful, because, you know, if you're doing this type of work, you expect that if you put resources in, your numbers will go down, but you may find that there's actually fluctuations that occur. And it's really helpful to understand the context of what's going on so you can explain those. The other piece that was set was the Braden scale completion on patient admission. We set a target for 83%, and it's been trending around 89 to 90%. So the majority of Bradens are being completed on admission, and that's extremely helpful information in terms of understanding risk. Just a quick sort of picture of, like, this was a ton of work, but this was the work that was done. There was a steering committee, there was corporate work that was being done. There were working groups that included education, documentation, and data reporting. And then there was also unit work that was being done that included critical care, and then our acute care and rehab unit. So all in all, we did about 24 clinical units with our pressure injury prevention work. And those units were identified by having four or more pressure injuries in a one-year period of time. So we were really monitoring and staying on top of what was going on in the clinical units by our reporting process. We also were working on therapeutic surface and bed frames. And so this was really a comprehensive strategy, because if a patient comes in and they're on a horrible mattress that's 20 years old, and, you know, they're uncomfortable, and so, or a bed frame that's not working, having that upgrading and making sure that patients are able to get on therapeutic surfaces, that you have enough. So we really worked, our goal was to get up 100% of our patients on therapeutic surfaces. When I left, we were up to 75%. And so, you know, the idea is to have everybody on a therapeutic surface. And so there was a committee working on that as well. But that actually took some endorsement from a senior level in order to do that work, because there's a lot of money involved with that. So, all right. So what I just wanted to share a little bit of what our data, and when you have decent data, what it tells you. And so this is from 22-23. So our most common occurrence of hospital-acquired pressure injuries were unstageable pressure injuries. And they were followed by stage 3 deep tissue injury and stage 4s. And so that's what we found when we're looking at our data. What's interesting, though, is the majority of our patients were transferred, discharged, or deceased before we see what happens to a lot of the unstageables pressure injuries. And so those of you who are working in long-term care and in the community, then you would be receiving our unstageable patients, our patients who have unstageable pressure injuries. And then you would see then the evolution of those pressure injuries in the community and in long-term care. And I always felt really sort of unsettled when we were doing that, because, you know, I know in those settings it can be very challenging to get the debridement and the things that you need at times for those unstageable pressure injuries. And so it's very interesting that we, you know, in acute care setting, we really, you know, don't know what happens to our unstageable patients. Patients with heel ulcers tend to be over 80, which I thought was very interesting with unstageable hospital-acquired pressure injuries. And so those patients, though, have higher Braden scales. So they were in the 15 to 18. So yeah, you think of them being at risk, but then, you know, you take that elderly age and that, you know, that threshold of the Braden scale being a little bit higher. And it really, like, that having this type of information really helps identify those patients and helps you then target specific type of interventions for different age groups. The patients with coccyx ulcers tended to be over 65 with unstageables and stage 3 hospital-acquired pressure injuries. And so I found that those patients stayed in the hospital longer. They tend to be more critical care patients. And so you actually had a chance to see and watch the unstageable evolves, and they tended to be stage 3s, but they had the lower Braden stage, lower Braden scale. So that sort of made a little bit more sense clinically. So one of the things that's extremely helpful for those of us who are seeing patients who are at risk is one of the things that we did is we actually developed an order set in our Epic system that could be used when patients are at risk. And it was called the Prevention of Pressure Injuries and Management of Stage 1 and 2 Pressure Injuries. So a nurse, an OT, a PT could initiate this order set, which had all of our interventions for pressure injury prevention on it. It would go to the doctor for signature and come back, and we could implement our pressure injury prevention strategies. And so that wasn't as well used as we thought it would be, but it was something that was available. And it also helped the NSWOCs not to have to write every single order every single time. That order set was pretty easy to use. We also developed prophylactic dressing documentation. And so one of our big strategies that we developed was our prophylactic dressing implementation. And so I'm going to be talking about that in a second and just talking about all the work that went into that. And then one of the things, and I think probably a lot of you have been engaged in this work, is the 4 T's, which is trigger, temperature, tone, and twinge in a documentation system. And so that is a more inclusive assessment for patients with darker skin tone. And so we wanted to make sure, because we certainly noticed that our patients with darker skin tones, once we saw their pressure injuries, they were way more developed than our patients with lighter skin tone. And so facilitating this improvement in our assessment and documentation was also a key piece of the work that was done. So just to show you what some of the interventions on our order set looked like: up for meals, therapeutic surface order, dietitian OTPT, so getting the consult started for the patients who are at risk or have early stage pressure injuries, getting them on a regular turning and repositioning schedule, elevating their heels, making sure that there's patient education and family education, and that the patient or families are also participating and involved in this. I think that, you know, we've all had experience with patients who will not stay on their sides, who roll back, who won't follow instructions for whatever reason, whether it's confusion or whether it's pain or whatever, but that education is really important. And just having this work available so that you can move on to more complex kind of work. So let me talk about that prophylactic dressing use. The prophylactic multi-layer dressings are widely used clinically due to convenience, quick application, and potential cost effectiveness. And so again, if you can prevent a pressure injury from happening, if you can prevent spending $9,000 to $222,000, per patient per pressure injury, then that prevention is extremely important. We used to do prevalence and incidence studies in the organization. And the last one I did in 2018, I calculated, and this was just a rough calculation. I took all our stage 2, stage 3s, and stage 4 and took costing per stage. And I estimated that that group of patients who had pressure injuries cost us $1.9 million. And that's without all of the patient implications around the disability and all of the patient-centered concerns that happen when a patient develops a pressure injury. So using these type of prophylactic dressings can be very effective, and really applying them to the high-risk areas, heels and coccyx areas. But it should really be part of a pressure injury prevention protocol with clear criteria, documentation standards, and unit-based education. And it's not just a one and done. It's a ongoing sort of, integrated into your orientation, integrated into your unit-based orientation, follow-ups to make sure it's being done, because it's a very important component of pressure injury prevention work. But this is a relatively new study I just wanted to share. This is called The Nurse's Perspective on the Use of Prophylactic Dressings to Prevent Pressure Injuries. So this was a qualitative study. It was done in Australia in 2024. 19 med-surg nurses were interviewed. And so this is just sort of a little bit of some of the things that we really need to think about when we're using prophylactic dressings, because this is their findings. Now, it's a small study, it's qualitative, but I think there's some points that we need to really think about out of the study, because implementing these dressings in a med-surg unit, one of the things that was noted is there's inconsistent practices with applications. And so some nurses actually put it in patients, whether they were low risk or high risk, everybody got prophylactic dressing. So everybody got a Mepalex border at that, or Mepalex at that point in time, regardless of whether or not they really needed it, just because it was an easier thing to do, because an attitude of the job done. So you put it on, you don't have to worry. And given the nursing pressures and the time constraints, the nurse would put it on and feel like they had done something positive for the patient. But it could then lead to missed skin assessments, because if you put it on and you leave it and you don't sort of follow through with the whole protocol, you can miss skin assessments. And so some of the recommendations came out of this, and I think this is really the take home for this, is clear guidelines, assessment-based selection, and process-based guidance for their applications. So making sure that you have the upfront work done so that people are very clear about who to put them on, what the assessment criteria are on. There's a expected skin surveillance that goes hand in hand with using them. And there's also assessments around dressing assessment and removal. And so I think this is an important piece of information when we're using prophylactic dressings. So what we did at Hamilton Health Sciences, we really took a standardized approach to education on our prophylactic dressings. And we developed, because in EPIC, you can work with your documentation standards. So we did a hand-in-hand approach where we introduced the prophylactic dressings, and we developed the Mepalex application criteria. So it was very clear what our criteria was. We also had pictures, so that it was a one-piece sort of shopping in terms of information. We also included ordering information as well, because there's nothing more frustrating than having to order something and then not having the information right at your fingertips. And so this piece of information described the dressing mechanism. We also introduced at that point in time our new prophylactic dressing documentation on what's called our LDA avatar. So we then had to change our documentation. And if you really look at your documentation systems, do they support you being able to document appropriately on preventative practices? And so, we had a good integumentary system, documentation system, and we had a good documentation system for pressure ulcers and pressure injuries, but we didn't have a great system for documenting prevention. And so we put all this together with the resources. And then this is, we did a pressure injury infograph. We did the tip sheet. We also had our vendor go around and support the education as well. So all of these strategies put together made a huge difference. And then one of the ways then we made sure that people could distinguish whether or not the Mepilex was there for prevention or was there for treatment was that when it was there for prevention, we taught people to put a P on the dressing so that people knew. And they knew that they had to lift and they had to peek under the dressing every shift, and they had to document. And just to show you what our this is our pressure injury infographics. So we did this, and every clinical unit received this. And this was in supply rooms, it was posted. So this was all of our preventative information, and then our a review of staging and our treatment plans, sort of one-stop shopping. And we did one for adults and we did one for pediatrics. And so this was an important piece of our rollout as well. And I just wanted to show you what in EPIC, which was our documentation system, what our documentation looked like that we added. Prophylactic dressing, we were able to take pictures, we're able to document, show the area. And so this was the expectation then around documentation. So we added that piece so that people could clearly document when they were using a prophylactic dressing. And this was the avatar that we used. In EPIC, you can use a lines, drains, and wounds avatar that shows where all of those are on the body. And we used a bullseye for our prevention then. And so for anywhere where we're using a preventative dressing, this is the avatar, this is our documentation. So people know when they pull up this documentation where the preventative dressings are. And just a sort of quick thought around the bias and skin assessment. As I mentioned before, we started to do some work around this as well. I know Wounds Canada is doing some work as well. I'm sure your NSWOC group is doing work on this. It's just acknowledging the bias and that fact that it's really important to do the 4 T's and have that as a part of your education and your documentation for skin assessments. So we are picking up pressure injuries early in our darker skin tone patients. So just a quick sort of note, we did use our tools that were already in place. So we are a CQI organization. You probably in your own organization have your own set of learning tools. We use CQIs. And so this is just sort of all the tools put together. But what the clinical units who were involved in the pressure injury prevention did was they implemented and really integrated pressure injury prevention in their status sheets, in their problem solving, in their reflections, and in their standard work. And as I mentioned, 24 clinical units participated over a 3-year period. All of the units got problem statements. They knew where they were starting from. They got observation cards and they got educational resources that were all the same. And this is just the work of one clinical unit. And so this clinical unit was struggling with their pressure injuries, and they really took a very deep dive into what was going on. And I love this root cause chart because I think that this is what we all struggle with in pressure injury prevention. Role definition. Who's doing the work, who's recommending the surfaces, who's doing the consults, who's telling the doctor, do we have the right knowledge? Do we understand the brain scale? I think that we ask for nurses to do a lot of assessments, and we need to make sure that nurses understand why they're doing their assessment and what are the implications of the assessment. And so understanding, the brain scale and what it really means to the patient is very important. Wound staging is so challenging, and I would just, ask that, you take every opportunity to teach staging to frontline staff nurses, because it is the most challenging and the hardest thing. It's all very interesting and looks great on paper, but when you're actually doing working with patients, I think wound staging is very challenging. And so doing some more work around that, are aware of the best practice around prophylactic measures, what are our standards of practice, like being very clear about what the expectations are. Are we really turning our patients? Are we mobilizing them? Are we documenting properly? Are we using the order sets? Are we getting things in place as quickly as possible? So these are all of the things that they identified as contributing to their to the problems around the pressure injuries. And then they were very clear about who was doing the work, when it was supposed to be done. And I think this is a sort of a very helpful thing. And so they really incorporated then pressure injury prevention into every day. They would do a safety huddle. They asked these questions. Is there anybody who needs an Isoflex? Anybody who's got a low Braden? Anybody who currently has a pressure ulcer? What's the stage? Who needs a consult? And so very helpful on a daily basis to be reminded of these things. And this is just their board. This is their work. This is the work that they did to work with their staff. And so I think it's quite a great example of what a unit can do. So we had our organizational work, and then we had units doing their work as well to really consolidate and to try to identify what their areas were and to develop strategies as well. And just, how am I doing for time here? Oh, I went way too fast. Our Mimosa Pro. And so we actually, talking about technology here, a handheld wireless scanner. And so we started a study using the Mimosa Pro. There's also a SEM scanners, which is another product. We chose the Mimosa Pro because it's a Canadian product. You can get support through Can Health for research dollars. And so we actually chose this. And so it's a really cool system, handheld wireless scanner that uses infrared light to non-invasively analyze tissue health. So again, using tools to help with early intervention. And so this is one of the tools that can be used. And like I mentioned, there's also a SEM scanner, which is another tool, and that's subepidural moisture. So it's looking for moisture from early pressure injury development. And this is this tool is using visual light, thermal, and oximetry. And so it can produce some very great images, and it's also approved for use in pediatric patients. And it's also built-in control for skin melanin. So it can be used for all patients of different skin tones. And so it's a very helpful tool for early pressure injury pickup. And so just my references and my final thoughts. I mean, you guys, NSWOCs have specialized knowledge for interprofessional teams, best practice, protocol development, and research, and that's right from your website. SWANs have knowledge, skill, and judgment to manage complex patients. So as I said before, pressure injury, wound care, pressure injury, ostomy care, for those of us who love it, it is a great job. It's fun. We get a chance to use all of our skills and helping our patients, but we also have this specialized knowledge that really, as content experts, set us up to be the ones who are really important in facilitating wound care, ostomy care, pressure injury prevention. And so, it's important to be the leader, to be the content expert, the researcher, and to have the evidence-based practice. And this is just sort of my thoughts from 43 years of practice, from being a manager, a clinician, a nurse practitioner. Know the costs and why you're recommending what you're recommending, and be ready for pushback. Because I can tell you, when we were rolling out our prophylactic dressings, there was a lot of pushback about costs. And, that's not necessarily a bad thing. Like, it shows that people are thinking, they want information, but be prepared. Be prepared to understand what the cost of prevention is and what the cost of pressure injuries are. Know what's going on in your organization. but be ready to really sort of talk about it and discuss it with people. Teach at every opportunity. Pressure staging is hard. And then, you know, there's also sort of like, why are we using the Braden scale? Like, why do I have to do this? So really helping people understand the tools that we're using, and being prepared to like speak to it. And just sort of some a tip, just as a manager, as I said, in how to engage organizational leadership. You do it with information. You do it with patient stories. You can bring your leader a patient story about something that's happening that's either worked really well or didn't work well. Those stories go up they go up the management hierarchy, and they're told again and again and again. And also bring your ideas for improvement. I mean, it may not be something that can be implemented right now, but bring your ideas, because opportunities, there's always a timing to things. I started out as a clinical nurse specialist working with director, and you know, the scope and the scale of the spread of pressure injury prevention at that point of time wasn't that great. But as the organizational engagement improved, the timing was there for the strategies to be put in place. So there's always a timing for things. So be ready with your ideas. So that's my talk. And I will stop sharing and go from there.
Thanks, Deborah. That was an amazing presentation, very comprehensive. I love how you have, you know, exemplified the great work that you and your organization has done in the prevention management of pressure injuries. Now, we do have a couple of questions that some of our NSWOC and SWAN colleagues have raised, and I'll take them up at this time, if that's okay with you.
Sure.
So we have a question from Rika Cadaves, and she says that, you know, it was a great presentation. She loved it. And does Hamilton Health Science have any ability to follow up with their happy patients once they're back in the community? For example, through outpatient wound care clinics. It would be interesting to see if there's a way to close the loop and determine whether those wounds eventually have healed.
Great question. And the answer is no. It was one of my great frustrations, is not having a clinic to bring patients back to do that sort of follow-up. So in an ideal world, that's what would be happening. And I don't think that, I mean, I always felt that greatly frustrated that I couldn't close that loop to be able to see what happened to our patients. So it's a great suggestion. That's really what should be happening. We should have a lot more ability to bring our patients back to the organizations that created the pressure injuries for support. And so great question. Thank you.
And there's another question here from Veronica Sorowick. Do you use Mimosa regularly, or was it part of a trial? If used regularly, would love to hear more. Who is scanning? How many devices and what patients are you scanning, etc.?
So it was a trial, and it was done on in the pediatric setting. It was done in med-surg units and orthopedics, and so I was just there for the trial component, and I think the implementation is a little bit more complicated, because then you have to buy machines, you have to do all that. So the trial period was occurring when I was there. It was very interesting to see what was happening and how the device picked up issues before you could even visually see them, but I don't have any sort of follow-up information at this point in time.
Thank you for that response. And we have a question from Alison De Silva. I love how you utilize EPIC and the LDA for the PIP documentation and dressing use. Then did you find it challenging getting this added into EPIC? Example is approvals, cost with adding to flow sheets, education, etc.
We have a very excellent clinical documentation team who, so we implemented EPIC in 2022 in the middle of the pandemic, and so that was great fun. But we went ahead and we did it, and so EPIC was a relatively new system to us, and so we have been able to work with our team. And with our clinical documentation person from EPIC, and with our committee to make these changes to EPIC. And so we basically created that prophylactic avatar from scratch. And we were able to implement it with the help of our EPIC team. And so it was a huge amount of work, but it was very satisfying to be able to make that change so that we had the documentation to match, what we were rolling out. And then in EPIC, the beauty of EPIC then is you can actually get data from that documentation. So then you can see whether and how many patients then are on a prophylactic dressing, how many patients then you were able to stop that prophylactic dressing because the area of concern was fine, or how many patients went on to develop a pressure injury. And so that was the data piece that we were looking at to try and capture out of EPIC. So you can pull that data. And so it's a system then that allows you to do that.
Thank you for that. And Vida Johnson just want to clarify that SWANs have knowledge, skill, and judgment to manage non-complex wounds. There's this collaborative relationship that we want to occur between SWANs and NSWOCs, that, SWANs will be working together with NSWOCs and referring any type of complex situations to our NSWOC colleagues.
Okay. Your website said complex wounds, so that's very interesting.
So we're going to have to check that one out.
Yeah.
But to be honest with you, it's interesting that we're doing this kind of talk because we want to really leverage the roles of both NSWOCs and SWANs and find a way to kind of see how this collaboration would look like. I know that there are organizations out there in different types of sectors of care that looking into how this relationship would look professionally, especially that there is a lack of resources available across, and seeing how we can leverage this opportunity to really mitigate the situation and address those concerns accordingly.
I love the SWAN role. I think that it is a fabulous opportunities for RPNs who are some of the most engaged people with wound care that I've ever seen, to be able to use their knowledge and skill and judgment. And so I love the role, and I would love to see that collaboration between SWANs and NSWOCs, because I think there's great opportunities to improve patient outcomes.
Great. So I don't see any other questions on the chat box, but I do have questions for you, Deborah.
Sure.
And this will be more like a conversation with you, because I like how you kind of presented and you did the framework, the hierarchy of how things are, both at different levels of the organization. And one of the things that stood out for me is the fact that you started off the conversation by saying, we're not really it's not been a common practice outside of the organization to really kind of collect data regarding patients that have pressure injuries. And I know I've been in organizations where we collect those information, but it may be a miss for some organizations, but it would be a good standard of practice to really find out that if a patient comes in, whether that's hospital acquired versus community acquired, would have to create that distinction that allows us to then ensure that those does not contribute to HAPIs. At the same time, also provide an opportunity to really reflect on where would be gaps in practice, or where would be gaps in the kind of like the continuum of care that could have prevented this pressure injury from occurring. So I love the fact that you kind of mentioned that. Now, my question is that in looking at your hospital targets for your corporate level, how did you determine that? What is your target rate that you're aiming for on either quarterly or monthly basis? And how did your team come up with that kind of target?
So that number was a result of looking at like data over a long period of time. So as I mentioned, we started collecting through our adverse event reporting system. We started collecting data back in 2016. And so we had a lot of data to look at. So our quality and performance team took a look at that data, and took recommendations to our senior team, and they actually came up with that number. And I think it's a recognition, and this was a lot of education to the senior team about the fact that we're never going to prevent in our acute care organization with our type of critical care. We're never going to be zero, so do not expect a zero. But what we can expect is a number every month. And so they started at around 14 or 15, and that's based on the numbers that we pulled over the years. And then we aimed for around 10. And so, I mean, it was just sort of decisions made around very sort of basic data, because it's hard to get data around pressure injuries. And so, like that was just the decision that was made at that level. And
I actually want to acknowledge that because you did kind of like a retrospective analysis of your data, and I know the challenges that exist in terms of really determining what could be the best number to target everyone is. As what
yes,
you said, 0 is amazing, but that will be an ideal world. But there are, patient population is different wherever you go, and that can
Yep.
increase the likelihood of either increasing the risk of pressure injury or may not increase the risk of pressure injuries.
Yep.
So I like the fact that you did a retrospective analysis of your patient population to really determine where is that sweet spot that you can aim initially and then work your way to a kind of like a more exceptional level that then dwindles the rates down as you go and proceed. And the important kind of like message of the story is, as an organization, as we work collectively together with senior management, even at the front lines, our goal is to kind of bring that number down close enough to 0 as possible, that it
Yep.
ensures that things that can be avoided should be avoided.
Absolutely. And I think that, Josh, that is the message right there. So thank you for summarizing things.
No worries. I do have more questions for you.
Okay.
We have plenty of time. So the other thing, it's not really a question, but a comment, but I like how you kind of, when you did talk about your pressure injuries and that most of your pressure injury and hospital-acquired pressure injuries are unstageable pressure injuries. You kind of hit a great point there when you mentioned that some of these individuals that develop these pressure injuries falls into the Braden scale risk score between 15 to 18.
Yep.
And I think that is an important point to make for everybody attending today and for all our clinicians out there, that even if somebody is at risk, you know what, it doesn't matter. They are still at risk of a pressure injury. And I think we in the organization that I work with, we also see patients developing stage 4s, even at that level. And sometimes people are so focused on the number as opposed to the individual risk factors, because at the end of the day, the Braden scale, although it's an amazing tool, it doesn't capture everything for us. It doesn't have comorbidities as part of its, a number that provides you a higher level of risk. So it's important for us to really understand holistically what the patient really look like that determines their likelihood of developing a pressure injury. So I actually really appreciate that you provided that information to everybody for people to be aware that, you know what, somebody at risk is still at risk, that we still have to do all our best at any possible mechanisms possible, either prophylactic means of pressure injury dressing, or even turning and repositioning schedule, or use of support surfaces that will redistribute pressure to ensure that they don't develop a pressure injury.
Yeah, and this is where our clinical judgment comes in. And so like the Braden scale doesn't really work great in critical care. So there are areas where the Braden scale does not really work that well. And there are areas where the Braden scale, can pinpoint, but I think it's also our clinical judgment. You look at a patient and you think, yeah, they're walking, but they're frail, they're not well nourished, but they are ambulatory, so their scale's a little bit better. But wait, you know what? They're all bony. And so I'm gonna start the process. So they may have a okay Braden scale score, but I'm looking and I'm thinking, nope, I'm gonna use my judgment, and I'm gonna start prophylactic dressings. I'm gonna get them on a therapeutic surface. We're gonna start this process because I see a problem. So our clinical judgment is also a big component.
Great. That's amazing, Deborah. And we have seen here some comments here from Sharon Hunter saying that we also see at the risk patients developing pressure injuries very, very quickly. And while Ola Esho also mentioned that, Braden scale is a great tool, but it has limitations, and subscores can be more indicative of a person's level of risk. So these are really, really amazing points. And at St. Joe's, Deraney did mention that we also include 15 to 18 to be considered even at high risk. So these are actually great eye openers that people are thinking outside the box and utilizing the tool to its fullest potential, not only to guide their decision making, but utilizing their own critical thinking in the process to identify these. So great, that's amazing. And the last one I really want to make is, I really like the fact that you highlight the 4 T's. And I think that's a great enabler to really focus on, especially when we're dealing with, variants of different skin tones. And it's really difficult to really see and justify what a stage 1 would be to somebody with, different skin tones. And we have to use any means possible, from inspection to palpation, to really identify and justify the fact of the presence of a pressure injury. So thank you for actually highlighting that for us today.
Yes, 4 T's are very, very important. Not something that I thought about quite frankly, until we started to see, pressure injuries in our darker skin tone patients that were well established. And it was like, oh, hang on, what did we miss? What did we miss here? And so, and I think for us, we started to really identify it over in peds, where we had darker skin tone patients developing pressure injuries, and our peds team was on that right away. And so, but good learning for adults, like we all need to be really aware of that type of situation and being on top of things as quickly as possible.
Awesome. So thank you once again, Deborah, for sharing your insights, the great work that you do, the framework that your organization have worked with. It was such an excellent presentation. It created a lot of insightful discussions here amongst our NSWOC and SWAN family. So on behalf of NSWOCC, we want to thank you for your time and expertise for sharing this morning with us today. And I want to also thank Mölnlycke for sponsoring this talk with us. And I just want to put a plug out there that also Mölnlycke has another sponsored presentation on our upcoming NSWOC conference in May. On May 24th, there will be a talk on the International Pressure Injury Prevention Guidelines by both Rosemary Hill and Caleb Below. At the same time, since Deborah has touched on the importance of really looking closely when we're looking at assessment of pressure injuries in different skin tones, there's a talk by Stephanie Furtado and Rebecca Dyke on Friday, May 2023 as well in the NSWOC conference. So for people who are coming to the conference, so these are talks related to pressure injuries that you really, really want to look into and attend. So with that, with no other further questions, with that being said, we're going to move on to our program. Thanks, Deborah. And now we're going to switch gears to really honing into highlighting the crucial roles of SWANs. Deborah have highlighted the valuable role of SWANs. So at this time, I would like to actually introduce and invite Shannon Murphy that will talk to us about the impact of SWANs in long-term care. Shannon Murphy is a long-term care RPN in Ottawa. She obtained her certification in 2005 and has worked in LTC since graduation. Shannon had been her facility's wound care champion prior to the creation of the Skin Wellness Associate Nurse Program, and in 2023, she graduated from the SWAN program. So over to hearing from Sharon about the incredible work that she's doing on our end. Over to you, Sharon. Shannon.
Hi, everyone. Thank you for having me. As Josh mentioned, my name is Shannon Murphy, and I'm an RPN SWAN located in Ottawa. I have been a nurse for more than 20 years. And for the last 17 years, I have worked in the unglamorous field known as long-term care. The pandemic brought to everyone's attention that there have been some serious challenges and shortcomings in long-term care. This was not shocking news to those of us who have worked in long-term care for any length of time. 20 years ago, I never imagined myself working in long-term care. But then I found my calling, my people, and my passion. Long-term care desperately needed passionate, caring nurses with a goal of, screen froze, with the goal of dispelling the notion that long-term care nurses are only pill pushers. I wanted to be one of those people. As previously mentioned, I was designated wound care champion in 2014 at my facility. In this role, I would facilitate visits with our NSWOC consultant, Vita Johnston. During my years with Vita, she kept mentioning and pushing that I had to do the SWAN program, which she had been working on behind the scenes for years. For those of you not aware, Vita is the lead academic advisor for the SWAN program. She said that I had a knack for skin and wellness. With Vita's and my workplace's encouragement and support, and not to mention a strong kick to the behind from my family, I completed cohort 5 of the SWAN program in 2023. After graduation, I continued to work as a floor nurse and part-time as a SWAN. As of March 2025, my facility realized the importance of the SWAN role, and my work made my role as a SWAN full-time. What is a SWAN? I'm sure if most of you have already heard of the term SWAN or even work with SWANs in practice. But what does a SWAN do? How are they trained? What do they bring to nursing care? SWANs are Skin Wellness Associate Nurses. The program was developed by nurses specialized in Wound, Ostomy, and Continence Canada's Wound, Ostomy, and Continence Institute, with the first cohort happening in January 2020. Little did they know what that year was going to bring for them. It is for practical nurses and diploma RNs to advance their knowledge in wound and ostomy incontinence management. It is a 5-month program broken down into 3 sections: wounds, ostomy, and continence. The program goal, which is directly from the Wound, Ostomy, and Continence Institute page, if I may quote directly, is the goal of the SWAN program is to educate and prepare more skilled wound, ostomy, and continent nurses across the spectrum of care. Now, I'd like you to think back to when you were in school studying nursing, be it diploma or degree. For some of us, it was a long time ago, for others, not so long ago. But the commonality is the lack of education, be it in nursing theory or in practice, with regards to wounds, continence, and ostomies. It was most likely a brief overview, and we all know there's only so much information that can be taught in 2 to 4 years, despite the skin being the largest organ in the body. The exposure that we have to skin, continence, and ostomies is usually limited to what we have seen in practicums, placements, and during our preceptorships. I personally had never seen pressure injuries, ostomies, lower limb ulcers, diabetic foot ulcers, lymphedema prior to graduation. We were not taught about continence. I had no idea of the different staging of skin tears prior to my first job in long-term care, let alone how to manage them. I have found that new graduates and veteran nurses alike just don't have the knowledge or skills because they just don't know. They haven't seen it. In my role as a SWAN, not only am I promoting skin wellness to my residents, but I'm educating my colleagues and mentoring the team members. Being a SWAN has made me understand the physiology and the stages of wound healing. It's like building a house. The program has given me the foundation of principles and theories for skin and wellness, and it's unlimited on how I do my renovations and customization. So what do I do in my house and facility? I work collaboratively with physicians, nurse practitioners, and NSWOCs to facilitate assessments, reassessments, treatments, and goals of care. I involve our dietitian with all areas of impaired skin to promote optimal healing. We have policies and practices in place for occupational therapy and physiotherapy referrals in-house. I'm responsible for completing assessments, scheduling assessments, and auditing assessments to ensure that there are no gaps in knowledge or treatment. And if they are, we fill those gaps. I make recommendations regarding products and how to use them. I meet with industry partners to maintain knowledge of programs, products, new and current education opportunities. For example, our preferred vendor has quarterly open houses on wound preventions, and we've made that a mandatory learning requirement for all of our frontline care staff. I help facilitate that, and we've made it available for every single shift, including night shift. When necessary, I make referral recommendations and facilitate the referral when possible. Having the knowledge that we all need expert help sometimes, this could be reaching out to an NSWOC for further guidance on a complicated wound. Reaching out to infectious disease, reaching out to dermatology, vascular services. This is why NSWOCs and SWANs are vital. They're filling the education gap that we all have when we first become nurses. Long-term care isn't what it used to be. First of all, we call our patients residents as we're entering their home every day. The face of long-term care has also changed over the years. It's not just your granny or grandpa anymore. We have residents in their 20s and 30s that call our facility home. This means that the average stay for our residents is going to change. Previously, residents spent 2.5 years at the end stage of their life in long-term care in Ontario. And for example, my youngest resident that I see in my role as a SWAN is currently 39 years old, and she's lived with us for the last 14 years. She has severe lymphedema, developmental delay, and major behavioral issues, which translates into she's going to be here for the rest of her life, and she's going to require these high-intensity skin needs for the duration of her life and her stay with us. Long-term care is now verging on complex continuing care. The care needs are greater, the comorbidities are more severe, with physical and mental health issues. My facility has 240 beds, and I'm presently the only SWAN working in the facility. In my practice setting, I actively see all areas of impaired skin, from dermatitis, lower leg ulcers, blisters, skin tears, wounds, ostomy. Basically, if the skin doesn't look normal, I'm seeing it. This enables early and appropriate treatment of impaired skin. I personally assess all stage 3 pressure injuries and above, and I manage all complicated wounds and treatment orders. In long-term care, there's been a significant history of bed sores, which is what they were called when I was in school. They then became pressure ulcers, and now we, of course, refer to them as pressure injuries. The name may have changed, but the issue remains long-standing in long-term care. It is so much of an issue that the Canadian Institute for Health Information tracks worsened pressure ulcers in long-term care. They haven't gotten around to changing the name yet. The indicator provides the percentage of long-term care residents whose stage 2 to 4 pressure ulcers worsened since their last quarterly assessment. The percentage of long-term care home residents who had worsened pressure ulcers since their last assessment varies between 2% and 3.5% across the LHIN region. The national average is 2.86%. My current percentage is 1.02%. My main goal in practice is prevention. If we're able to prevent a wound from happening, if we're not able to prevent a wound from happening, the goal is healing and resolving. And at the very least, I want to prevent the wound from getting worse or infected. To make dressing changes a little easier for the floor staff, I've created dressing kits for the registered staff to use when completing dressing changes. The kits are ready to grab with everything required for a basic dressing change, including a dressing tray, sterile gloves, paper ruler, sterile scissors, non-barrier wipe, and sterile applicators and extra sterile gauze. I also have resident-specific dressing kits tailored towards the resident's wound care need. This ensures the nurse is using the correct supplies. It makes their job a little easier, and it assists with infection rates. The reason we have to make our RPN's jobs a little easier in long-term care is the average patient load or resident load that they are looking after is between 28 and 34 residents. In the last 5 years, we're seeing more and more diabetics being admitted at a younger age, resulting in more residents at risk for later amputation. We find, not to generalize too much, that these residents are being admitted likely due to poor management of their diabetes, poor compliance resulting in challenges in proper treatment, and in addition to multiple comorbidities. At my facility, we're implementing screening for new admissions that have a diagnosis of diabetes. We are pre-screening for sensory loss, neuropathy, and actual foot assessment of that specific physiology of that resident's foot. We will repeat this quarterly and as needed, in addition to the daily head-to-toe assessments that our frontline staff are doing to ensure that there's no new areas of impairment on the feet. And this past August, I had the opportunity to meet with the Minister of Long-Term Care, the Honorable Natalie Kuzendova-Bashta, at my facility with Dr. Kimberly LeBlanc. She was there representing the NSWOC Wound, Ostomy, and Continence Institute. We discussed my role as a SWAN, the problems that new graduates face entering long-term care, and when it comes to assessing and caring for skin issues. How could we improve continence and the quality of life for our residents? The result of this meeting was a partnership between the Wound, Ostomy and Continence Institute and the Ontario Ministry of Long-Term Care, creating a groundbreaking initiative to enhance wound, ostomy, and continence care expertise in Ontario's long-term care homes. The Ontario Minister of Long-Term Care granted the Skin Wound Professional Growth Fund, providing a one-time funding for the 2024-2025 fiscal year. The funding will support the education, training, and fees for 90 nurses to become SWANs. This investment ensures that the long-term care homes will improve the quality of care provided to their residents. These ideas and concepts and achievements would not have been possible prior to my SWAN training. Now, finally, I would like to share with you a very brief success story that I had that, again, would not have been possible without the advanced education, knowledge, and skills that I received from the SWAN program. So I'm just going to share my screen. All right. Okay, so this was me and the Minister of Long-Term Care. So this is just very brief success story. So a family consented to me sharing these images with you. So this was an 81-year-old woman with advanced dementia. She was highly resistive with care, physically responsive with all aspects of care, so much so that she's followed by the Behavioral Support of Ontario. She has advanced kidney disease and elevated TSH. She initially developed a blister on her right heel in June 2024, the beginning of June. We implemented an OT assessment right away, pressure relieving boots, and a repositioning schedule. The registered dietitian was consulted and the appropriate supplements ordered. Approximately June 17th, staff determined that the right heel was a stage 3 pressure injury, so they came up with a treatment plan. That being said, the wound continued to deteriorate and this resident's behaviors continued to increase. Around July 11th, they noticed a very strong odor coming from the wound and more exudates. So we swabbed it for a culture and sensitivity, came back infected, and for some reason there was a slight delay in the culture and the antibiotics being initiated. Unfortunately, I was also on vacation during this time, so I did not actually see the wound until July 25th. So that being said, warning graphic images ahead. Now, I'm sure everybody's okay with that, but just in case you're not, the heads up is there. So this is what the wound looked like on June 30th. As you can see, not very nice looking whatsoever. Sorry for the fuzziness, but on the 25th when I saw it, this is what the wound looked like. So I was requested to see her for the deteriorating heel wound, and it had progressed to a stage X. She was on antibiotics. There was a strong odor present. And honestly, based on her kidney disease, her poor nutrition, her advanced dementia, I really didn't think this wound was going to heal. That being said, I came up with a treatment plan based on an education session that had been provided by Ergo Medical. So, and I had some samples in my practice, and I figured, why not? We'll give it a shot. The worst that could happen is that it stays stalled. I didn't think it was really going to get worse, but I didn't know. I had told the husband, though, I did not think it would really heal, and that our goal of care should be comfort, minimize the odor. He agreed for that. That being said, I started a routine, and 19 days later, this is what the wound looked like. And the odor had resolved by August 20th. Now, the wound continued to improve weekly. So this was September 15th. And October 15th, this is what we were looking at. And as you can see, there's still a very tiny open area. So we continued the dressings for another 2 weeks. And then on November 1st, I discontinued all current orders and made a recommendation for a betadine paint. And the physician agreed, and we did that until the scab kept reducing to the point that this is what we ended up with in December. So this is my success story, and this would not have been possible if I didn't have my SWAN certification, a great nursing team to follow the treatment plan, and a collaborative approach between the dietitian, the medical team, physio, OT, and the support of the family. So this is just showing you how much your SWANs can bring to the facility. It can be the difference between, you know, treating it in-house or having to send the poor person out. Now, realistically, it's not reasonable to send this particular person out. She has dementia. Sending her out is going to be worse for her. We have to know our population and try and treat them here. And you have to know that you don't know everything. And if you don't, reach out to your NSWOCs. Reach out to your team. Ideas come together. And that's my presentation for today. If anybody has any questions, feel free.
So first and foremost, Shannon, that was an incredible presentation of the incredible work that you do. And as I'm listening to you, I'm seeing all this like thumbs up, hearts everywhere, filling my screen. So amazing work that you're doing, and just exemplifies the great work and role of SWANs in LTCs. And before I give further my comments, actually, there was just a question out there that I saw that I would like to ask. And it's a question that says, they love your presentation, your passion for long-term care, and we thank you for what you do. Do you officially have kind of like an escalation point for any complex wounds to an NSWOC? That's the first question that they have asked. So you can answer that one first.
Actually, yes. So I frequently reach out. When my program was happening for the cohort 5, they had collaborated with the NSWOC Wound Institute to have multiple people from extended care attend the SWAN training and the NSWOC training. So what we have in-house is I have the ability to reach out to further NSWOCs within various and extended cares across Canada for consults. That being said, that doesn't always happen in a timely fashion. So fortunately for me, I'm in Ottawa, and I have some great mentors and resources with Kim LeBlanc and with Vita Johnson, being able to answer questions and support me and direct me in the right direction. And again, super fortunate being in Ottawa that we have the Limb Preservation Clinic with Christine Murphy here as well that we can reach out to.
Great. Thanks for highlighting those great links that you have, especially in the Ottawa region. Now, a follow-up question to that is, what are your suggestions for new SWAN grads that maybe don't have a mentor or a wound network in long-term care to navigate and treat such complex wounds and situations?
Be part of the SWAN community of practice first and foremost, because we do have that. So once the SWANs graduate their program, they should still be involved within their community of practice. And you know what? If you don't have one within your facility, create one. The only way that you're going to do these things is by building your network. And we're such a small group right now that we do have to rely on each other. Like, hey, I'm stuck on this. Do you guys have any ideas? And, you know, when we're going through the SWAN program, you're being mentored by an NSWOC. So all of your assignments are being sent to your NSWOC for grading, for marking. And for example, Susan Chandler was my instructor in the program, and I consider her a person that I can reach out to. Like, get to know your instructors. They're there for you. The whole purpose of these people teaching the SWAN program is they're passionate about helping the new nurses. And so rely on them. They're offering their support and guidance. Take it. That's the biggest thing.
Thanks, Shannon, for that. And you know what, as what I always open this regional meetings with is my SWAN and NSWOC family. Because we are a family of a small niche of, specialized nurses. And I think we really have to work closely together and network and collaborate with each other, because what my challenges would be may be a challenge for another person. And together, two heads or more heads are better than one. And I think we have to come together as a team and not feel intimidated to reach out at any point in time, because we are all learning together with, amongst each other as we go through and deal with all these complex situations.
Absolutely.
And there's a question here from Rika Cadavis. She says that, thank you for sharing how SWANs are making an impact in LTCs. In your role, are you exclusively hired as a SWAN? One of the many barriers we've noticed in many LTC settings is the RPNs are often expected to take on dual roles, acting as a SWAN while also managing a unit, which can make it challenging. So that's first part of the question.
Okay, so yeah, I can attest to that firsthand. Because, since 2014, I had been the wound care champion, which was kind of working in almost like an unregulated SWAN type role without the knowledge, skills, or education to do what I was doing. That being said, I was given 2 days a week to manage 240 people. That's not reasonable or feasible. I'm one person, I'm a human being, I'm not a robot. So I hear what you're saying. And generally, if you're given a skin and wound day, you guys are the first ones to be pulled if we're short. It happens. It's reality. What made the difference, quite honestly, is me having my numbers down, my percentage numbers, the quality indicators, and them seeing the results that I was bringing to the home. This last case study really pushed things over the edge, because I presented that to the corporate team and they're like, wow, okay, we need to have this full time. If she can do this, then there's no reason why we can't have these in all of our facilities. So that really is the goal of at least Extendicare, the company that I work for, is that we're going to have a SWAN in every single one of our homes. Because knowledge is power. And quite honestly, I know when Vita was here, some of the time she was seeing, a stage 2 pressure injury. And NSWOC should never really be seeing a stage 2 pressure injury in long-term care. That's something that a SWAN can certainly handle with their skills and knowledge.
So thanks, Shannon, for that answer. And I think, an instrumental, I think a pivotal point that you made there is, showing the results, right? The return of investment that you've done.
Absolutely. If you show your results, your company is going to, or your company, your facility, wherever you work, they're more result driven. They like numbers. They like statistics. They want their numbers to look good for corporate. That being said, just keep doing what you're doing. Keep advocating for yourself, that prevention is the key. And, for the SWANs out there, throw out the quality indicators. Your ADOCs, your DOCs know that this is something that the ministry looks at, and nobody wants to have a high percentage for pressure injuries.
Thanks for reinforcing the data-driven society that we are in. And then that will also impact the influence funding for us across the board. Now, the second part of this question, because you answered that component, is that how would you encourage to support RPNs in pursuing the SWAN education so they can eventually become wound care champions and experts within their LTC homes?
Okay, so first and foremost, have a passion. Have a passion for your residents and have a passion for skin and wound. I'm not going to lie, when I started in nursing care, I didn't necessarily find a passion in pressure injuries, but it's come. And what's brought it to light and fruition was success. If you have a success in resolving or healing a wound, you feel good about yourself. You did that. You came up with that treatment plan. And, you know, it's building the confidence that moving forward, that, hey, I can do this. And we want people who are SWANs who are passionate about their residents and about skin wellness, because it's not just about pressure injuries, it's also about continence, it's about ostomies, it's the whole package. So we can't just be tunnel vision for one thing. We have to see the whole picture and how we can change long-term care and the quality of life for our residents in long-term care. And the biggest thing is you got to be passionate. You want to be here. If you don't want to be here, don't sign up. Don't do it. It's high intensity. Like they need your dedication. They need your passion.
I love that point, Shannon, because it's one thing to be knowledgeable and to be prepared to be an expert in wound ostomy continence, but it's also one thing to be passionate about it. Like we need people that has the heart to do and have an impact for people, not just kind of like coming in there, getting paid for the position, but getting there to really make a difference and influence positively on the person's life. So thank you for highlighting that. We have great comments on the chat box, but before I go through that, I do have a couple of things I want to reflect upon in your presentation and And one of the things that you raised, aside from the massive ratio that you have in LTC from 1 person to 28 to 34 clients and residents, is the vision that you mentioned is that the transition of LTC clients to becoming more of a CCC population. And I can actually strongly attest to that because I had my fair share of being consulted to go to an LTC to see some of the people, and I was just blown away and surprised where what you've shown me is sometimes when patients have, their calcaneus like hanging off the balance, that should have been part of either an acute care setting or even been seen in a CCC environment. So that's really incredible that you mentioned that here in this presentation to raise awareness about the level of complexity of our clients that are living in LTC at this point in time. What we're seeing 10, 20 years ago is no longer the same types of individuals that we are seeing today. So thank you for raising that, Shannon. And because it really leverages the need of that specialized group of nurses, such as SWANs and NSWOCs, to be present at all times. And as what we have mentioned, I think in the presentation that Kim LeBlanc did before, there is that lack of expertise across LTCs. And I think you have seen that also in practice in your area. And think alone, Ontario is a massive province. How much more in areas where there is not much resources available? Right. So I think it's important for us to really advocate, and what you've done in your role of advocacy, you made a difference and you have been an instrumental component of making that funding possible for 90 SWANs to actually be educated to be a SWAN moving forward. So kudos to you and thank you for doing that.
Thank you.
So a comment here from Jason Lau. So thank you, Shannon, for your unwavering dedication to LTC. Having spent over 10 years in long-term care myself, I truly understand just how challenging and demanding the environment can be. Your commitment does not go unnoticed, and it's deeply appreciated.
Thank you very much.
And of course, Vita Johnson is here watching over you. Bravo, Shannon.
Hi, Vita.
Your impact as a SWAN in your home and in Ontario. So proud that to have worked with you. And again, Jody Matsala says, excellent presentation. Totally agree with your passion. And you know what, just sitting here, I'm just trying to hold myself because I can feel this passionate vibe from you just flowing through the screen. So really thank you for that, for inspiring us with your talk today, Shannon.
Thank you.
Okay, so I'm just going to check the Q&A. There's one question here. Shannon, could you highlight, it's from Vita Johnston, can you highlight how SWANs can impact continence care in LTC?
Well, continence is not a normal part of aging, as we all know. And unfortunately, it's still treated as such in long-term care. So what we really need to do is change that mentality that incontinence is normal. And our demographic has changed. It's not all these 80, 90, 100-year-old ladies that are dribbling urine. We could have somebody who's 25 here and they're wanting to manage, their incontinence. So implementing retraining of the bladder, and because SWANs can do that, we have the knowledge to understand what type of incontinence it is and how to deal with it. And if we can lower the number of incontinence products, at the end of the day, that's dollars to our bosses, and everybody likes saving money. And if they can lower the cost, because let's face it, at the end of the day, in long-term care, for-profit homes, it is all about the profit. So if they can keep their numbers down, they're very happy. But for us as humans, if we can give somebody the dignity of having their continence back, why the heck not? You know, like if we have the capability, the resources, the knowledge, we have physiotherapy here. We can implement pelvic floor exercises. There's no reason why somebody has to be, and I hate this term, has to be in a diaper in their 40s. That can be totally eliminated in most cases.
Thanks for that, Shannon. And again, you have raised the bar and kind of like raised awareness on this one, because the people have misconception about continence that they're seeing as what you have mentioned, part of normal aging, but it's not. And we have to do our due diligence to really prevent that from happening. And sometimes these, episodes of incontinence are due because of sometimes of the lack of resources available. Then that promote that kind of level of incontinence, as opposed to promoting them in their toileting schedules and supporting them in the process. So we have a couple of comments here again. Very proud of you and all that you continue to do, from Jennifer Bilby. And again, from Denise, thank you, Shannon, for representing the SWAN community from a newbie SWAN person. So
well, welcome to the family.
Thank you. Thank you. Okay, so it's now 10:38. I don't see any other questions, Q&A and comments on the chat box. At this time, I probably will give people at least 5 minutes for a bio break. So before we proceed on to Lori's presentation with a focus on ostomy, so that I'll be excited to hear about that. So please come back at around 10:43 in time for our 10:45 session, and see you soon. Okay, so welcome back, everybody. So we're now switching gears with our focused education with a clear and tunnel vision towards ostomy care. And this session will be sponsored by Convatec, focusing on the use of convexity for the management of ostomies. But before I pass it on to Lori, I'll give her a little bit of an introduction about her. So Lori Zozzolotto is a nurse specialized in wound ostomy and continence care, and has worked as a clinical nurse specialist for Convatec for 6 years, covering for Ontario and Atlantic provinces. She has been a nurse for over 17 years, beginning her career as a registered practical nurse, bridging to become a registered nurse and then an NSWOC. Lori has worked in hospitals, clinics, schools, and home care settings. Lori loves to volunteer, and in 2023 received the Registered Nurse Association of Ontario Award of Merit for her efforts in nursing. Prior to becoming an NSWOC, Lori was a birth and postpartum doula. So over to Lori.
Thank you. Can you hear me okay?
Yep, loud and clear.
I'm just going to share my screen. Just let me know when you,
Can see it from my end.
Okay, I'm just going to, there we go. Okay, thank you everyone for joining us. And thank you, Shannon, for that amazing presentation. You're a tough act to follow. So these are going to be our learning objectives today. We're going to look at continence, convexity, and how we can use it to help our patients. So I just want to give a quick nod to these to this international team of people that helped create this presentation and the new convexity product I'm going to talk about. So as we saw from our learning objectives, we're going to talk about identifying the 3 assessment steps for the evaluation of a person with an ostomy. So we're going to start with some back to basics, which is, what does the assessment, how does an assessment begin actually? So in this room, I'm pretty sure that many of us are very familiar with the plan of care of ostomies And the issue, the considerations that we have when assessing an ostomate, none of us are ever going to walk into a room and, just pick a pouch based on the fact that, whether or not we like the color. We're going to base our assessments on our education and our personal experience. However, unfortunately, not everyone in the world has the expertise or the language to know why they are selecting certain products. But luckily for us, in 2021, there was a consensus statement that was published in the JWOCN that explored the characteristics of convexity and came up with a consensus language so that we can all use to speak the same language about convexity. One of the first things that assessments we want to do when assessing for stoma pouching is that we want to assess our patients in various positions. We know that there are some clinicians that like to assess people in the supine position, and that our patients like to receive care sort of in the supine position, lying like kings and queens. But that doesn't really tell enough of the story. We need to look at the whole person. So, because the stoma can shift in shape and size by up to 5 millimeters, depending upon the position that the person is in, and their abdominal contours can change as they move as well. So, in order to secure a good fit, we want to examine our people in many different positions. So, what does a good stoma look like? Well, it looks like this lovely one here that you see in this photo here, that we probably have never seen again since our NSWOC, our nursing days, where we saw a beautiful stoma like this that had great peristomal skin, that there's no creases or fold. The stoma had a great protrusion. The os is pointed upwards, and that we have a nicely shaped abdomen. When we're doing those stoma assessments, we want to look at the color of the stoma. We want to look at the location and position of the os. We want to look at the protrusion of the stoma. Is it budded? Is it flush? Is it retracted? We want to look at the mucocutaneous junction to make sure that there's no separation or threat of separation. And we want to look at the consistency of the effluence and, of course, the size of the stoma. So now we go from that happy stoma that we saw in the previous pages, and we're going to look at the not so happy stomas that we need to assess, right? We know we need to take a different approach to patients with abdomens like this. In the first picture, we can see the patient has a rigid abdomen with two separate stomas that are very close together. In the second one, we see a retracted stoma, despite the fact that they are using, the red rubber catheter. In the third picture, off to the right there, we see a flush stoma on a soft abdomen that has obvious peristomal MASD. And in picture 4 to the far right, we can see how on this obese abdomen, the stoma has become retracted, right? I may be biased in saying this, but I feel that the best chance an ostomate has of having a beautiful stoma is to be assessed preoperatively by an ostomy nurse. And that is because a badly located stoma can be a life sentence to an ostomate for a life of skin issues, right? While there is not a ton of evidence in our WOCC practice about the statistics regarding what happens when people are marked versus not marked. There was a meta-analysis in 2020 in the JWOCN entitled Preoperative Site Markings, and that it decreased stoma and peristomal complications, and that was by Mei Su and colleagues out of Taiwan. And this meta-analysis concluded that perioperative stoma site markings are associated with reduced occurrences of stoma and peristomal skin complications, and that this should be considered a standard of preoperative care. Another part of our assessment is going to be assessing for stomal complications. As nurses, we want to find a solution to to help our other bedside nurses help patients with these types of skin issues. And we can do that by using the language of the 5 characteristics of convexity to help communicate the needs of our patients with challenging stomas and peristomal planes. The importance of skin health cannot be emphasized enough, because aside from poorly sited stoma, skin health is an integral part of the ostomate's life and a stoma assessment. While most ostomates think that the stoma runs the show, we know it's actually the skin. A poor fitting appliance can start a vicious cycle of leakage, leading to effluent damage of the skin, creating unhealthy skin, leading to the appliance falling off, and the vicious cycle continues on and on and on. What we want is to have the ideal fit. We can see this patient here has a little bit of concaveness around their stoma and a soft abdomen. This person came to the clinic, and the previous clinicians didn't know how to treat the peristomal MASD. So this patient presented to their clinic with barrier cream and diapers covering their abdomen. Luckily, the clinic nurses there were able to clear it up with the right pouching system to ensure that the patient had the right fit. Again, knowledge in skincare is so important. So these are according to literature, the top 10 reasons for leakage. Incorrect size, application technique, liquid output, a flush or retracted stoma, skin creases and folds, stomas that change with people's position, inadequate skin cleansing, peristomal skin breakdown, wrong barrier selection, and poor pouch adherence, which again emphasizes the need for the right pouch and the right size that are put on right. So we're going to look at wafer assessment after removal. I often say that being a stoma nurse is a little bit like being a detective. We're always looking for hidden clues. And one of the greatest tools that an ostomy nurse can do is looking at the wafer after they take it off. Before, don't just throw it in the garbage right away. Take a look at the back, because you can see valuable clues about the fit of your wafer. So for example, here, most patients looking at this will think that by looking at the first 4 wafers here, that they don't think that there's a leak. Patients often only think that they are leaking if the effluent comes outside of the system. But we know that the first 4 are so-called silent leaks that can cause a lot of pain and skin damage without having a catastrophic leak where there is stool or urine on the person's clothes. Patients need to be reminded that any burning or itching, even without obvious leakage or blowout, means that the flange needs to be changed. So again, this is a wafer assessment after, an example of wafer assessment after removal. You can see the picture on the far right there. This patient thought she wasn't leaking because she was getting 3 to 4 day wear time. However, she did say that she was experiencing pain, but she thought that was normal for a person with a stoma. Through education and assessment, we had the opportunity to help this patient find the ideal fit so that they didn't have this kind of pain or leakage that could lead to serious issues later on. So getting an ideal fit in an uncomplicated patient, we're going to do the patient assessment. We're going to perform a patient assessment. We're going to look at the abdomen, the stoma, and the peristomal skin. We're going to consider the patient's ability to use products, their dexterity, and their preference for products, and their lifestyle considerations. What did they do on a daily basis, or in their free time? How can we help them embrace that and live their best life ever? So when should we use convexity? We want to look at some of these factors that you see listed here, right? that may lead to the need for convexity. For example, someone that has a stoma that's budded but continues to have repetitive leaks, people with flush or retracted stomas, skin folds, soft abdomens, etc. Used to be that we avoided convexity post-op, but in 2022, Caldwell created an amazing article that talked about the use of convexity systems in the post-op period, and this really sort of changed how we all thought about using soft convexity in the post-op period. So no one really knows where convexity originated, and all of the manufacturers all have their own kinds of convexity. I encourage everyone to read the Hotline article from 2017 that talks about the use of convexity in ostomy care, as well as Hotline's 2013, which also talks about the use of convexity in ostomies. Now, not all convexity is the same. I think we all know about this. When I first started nursing, I was taught by my preceptor pretty much the standard for care with convexity was that if you had a jelly belly, you were going to use firm convexity. And if you had a firm belly, you were going to use softer convexity. And now we have so many more products that run the gamut that are more comfortable and address the individual needs of our patients. So we're not using a one-size-fits-all anymore for just anyone, right? And with the language of the article that we learned in the 5 characteristics of convexity, we now have a language that we can use so that we're all speaking the same language to choose the right pouch for our patients based on their own assessment. These are the 3 articles that have set the tone that I've mentioned, and I encourage everyone to read these. The 3 articles are, again, the 2017 Joe Hotline article that you see listed here, and the 2021 Laura McNichols and her group made some amazing recommendations for the characteristics of convexity. And then most recently, excuse me, Jan Caldwell and her team wrote an article pertaining to convexity in the post-op page. So we're really seeing a lot more information and evidence about the use of correctly used convexity throughout the gamut of the ostomate's entire lifetime, from post-op through their life. So what are the 5 characteristics of convexity? They were listed in this article that you see here, which was the result of an international consensus panel by the clinicians that you see listed here. And they included depth, compressibility, excuse me, tension location, slope, and flexibility. And we're going to talk about those later, because before this, we didn't have an agreed upon language to talk about convexity and its needs, right? So tension location is the position in which the barrier exerts downward and outward pressure on the peristomal topography. And hopefully my video is going to work because it's going to show both of them. The first one we are going to see here is central tension for the protrusion of the stoma. So you can see how the tension is around the center of the stoma, whereas peripheral tension is used to flatten out skin contours. So you see that the tension is further out. So again, this shows that one size does not fit all, because you know, if you're using convexity that just pops up on someone that has skin rolls and vice versa, you're not perhaps going to have the results that you're hoping for. Oops, there I am. Okay. So how does tension location work with ostomies, and how did Convatec apply that technology to convexity? Well, they used a thing called finite element analysis, which is similar to the pressure injury technology that we use to analyze pressure injuries in pressure mapping for those injuries, and how they interface with the abdomen. And you can see here that they actually came up with 8 different pressure distributions. So what is finite element analysis? You can see why we call it the FEA for short, because that's a mouthful, right? Well, the FEA is a way that engineers can design something and then break it down into individual components to see how it will react to different strains here. In this case, we're using the example of a bridge. And so, for example, if you designed a bridge and then broke it down into smaller parts or finite elements, you'd want to model it to see how it would behave when you drove a truck over different parts of the bridge, so you knew it wouldn't collapse. So FEA modeling allows engineers to do this before they actually build the bridge to know where the pressure points are going to be. So they took this very high-tech, brilliant technology, and they use the FEA modeling to use it for medical devices. So as I mentioned before, this type of modeling has been used in pressure injury prevention to show the efficacy of foam dressings for the prevention of pressure injuries. On the far right, we can see how FEA was used in ostomy care to demonstrate how the placement of the stoma in the abdominal wall affects the strain on the area in the relation to the formation of a peristoma hernia. So we are on the cusp of such high-tech breakthroughs in wound, ostomy, and continence care, I tell you. So much like our bridge concept, what they did was they took the FEA technology and then they also created a representative abdominal wall model to use it to test the FEA on. So they used a systemic review to identify actual tissue thickness measurements, and they modeled each layer material property as to how it would stretch and deform responding to tensile strength and strain. And this model not only took each individual tissue layer into account to bridge the model, but it specifically demonstrated the change in the tissue when a stoma is created and then sutured down to the skin. So they really use science to create the model. So this is the model that you can see in the cross section. There is a simulated impact of the convex base plate that's mated to the abdominal wall, with the impact of the stoma accounted for when the tissue is loaded with various convex wafers. And we're going to see how that pressure mapping looks in the next couple slides. Stick with me, this is all going to make sense shortly. So the result of the model you can see here is that it provides a graphical representation of the magnitude of force and its concentration around the stoma, or distribution away from the stoma. So that's similar to a bullseye with the different concentric rings. So the darker the rings, the more concerted the force. This allows you to visualize how and where a convex wafer may apply different pressure based on both its width and its depth. So these were the measurements that they took. So the model again demonstrated how the forces help to move the skin and applying various levels of tissue compression that depends upon the type of convex base plate applied. So this will help us in a moment when we're going to discuss what type of impact we may need on the tissues for a specific clinical presentation. Lots of sciencey stuff. So these are the results. The results of this model are very important because within this specific manufacturer's assortment, we can see there are 8 distinct convexity tension locations. Having multiple tension locations within the range of convexity you use could allow you to respond to a greater patient variability. Here you can see in the top 4 boxes, we see the different types of central tension. So you can see that if you wanted a stoma to pop out, you're going to want that tension centrally around the stoma to make it pop out. And in the second section, you can see the bottom 4 boxes demonstrate different peripheral tensions. So again, if you've got a great stoma that's budded, but you've got maybe some skin folds or something that you want to move out of the way, you're going to use that peripheral tension to move that out of the way and get your convexity to stick the way you want it. So other things that you can use this kind of convexity to really custom design a convexity for your patient is, let's say, for example, you have a patient who has cancer and they're edematous, and you have a concern that there might be some MCJ. You can look at this pressure map modeling and understand that using more peripheral tension location and a 3.5 millimeter depth will decrease the forces of MCJ as opposed to using more centrally located pressure. So again, to make this all easier, we want to talk about what are we trying to do? Are we trying to pop up your stoma, or are you trying to flatten out your peristomal topography? So we're going to assess the abdomen and the stoma and the peristomal plane, and we're going to ask, does the stoma appear flush, retracted? Do we have effluent draining right at skin level? In that case, you're going to want to pop up the stoma to create a tight seal at the skin level through that central tension in the center. But if you've got skin folds or creases extending away from the stoma, in that case, you're going to want to flatten out those skin folds and creases, and you're going to want to use your peripheral tension, which you can see in the bottom there with the bullseye ring is further out. So you are guiding the tension of your convexity to where you want it, right? You want to notice how much force is less when the width is wider and the depth is more shallow. So how do we translate this knowledge into practice? We're going to look at some case studies. Well, we're going to, again, we're going to examine the language of the five characteristics of convexity to get an ideal fit, so we understand how to make our convexity work for us. So they established the language for tension location, and that is being that tension location is the position at which the convex dome exerts the downward force onto the peristoma topography. The depth of your convexity is the measurement from the apex to the dome of the base, and the angle of the slope is, of course, the angle from the base of the convex skin barrier to the apex of the dome. Compressibility is defined as the capacity of the convex dome to be displaced or flattened. And finally, flexibility is how easily can the barrier bend when you've taken the wrapper off. So now that we have this consensus on the language that we can use, it can really help us to talk to each other and to our patients and figure out how to use these characteristics to get the best convexity possible. So we're going to look at a couple of case studies. So in this case here, we have a stoma that is flush. The abdomen is soft. We're having lots of liquid stool, and the peristomal plane is flat. So you can see here through our FEA that when they applied the computer model, you can see that our bullseye is telling us to use that peripheral to use the peripheral tension, so further out to smooth things out. And you can see when the model is compressed onto your right there in steps 3 and 4, how that convexity is going to make the stoma pop out. So in our next case here, we have a 64-year-old with 64-year-old with an end ileostomy. This patient was discharged home in a flat barrier, and she came to her clinic with terrible MASD. The picture here, as terrible as it is, was taken a few days after she was finally in the right pouch. Her abdomen is soft and the stoma is in the right upper quadrant. So based on the FEA and what we know about the characteristics of convexity, a convexity that was selected had a centrotension location to apply force immediately around the stoma. And because this type of base plate compressed the skin right around the stoma, and also the patient had some concavity around the stoma, so they used a deeper convexity, which was 7 millimeters. And I'm going to show you what that looked like. So again, you can see the FEA model that they use shows you where the best pressure we want around the stoma. And they came up again with, we want to have a deeper convexity with the 7 millimeters, and we want central tension around that stoma to make it pop out. Oh, gonna make sure I get all my photos this time. Oh, and I went too far. Go back one. So in this case here, again, we're translating convexity characteristics into product. And in this case, we have a 57-year-old obese female following emergent surgery for an ileostomy. She had diverticulitis. Her output is liquid, but her MCJ kind of looked questionable. It's a little bit blurry, but you can kind of see that the mucocutaneous junction is kind of coming apart. And the patient has a lot of edema. So again, looking at using the characteristics of the FEA, we decided that we're going to go with peripheral tension. We're going to use a shallow depth because we don't want to put too much pressure on that MCJ, and we want to have the greatest compressibility possible. We want it to be soft. And we want to have a low angle of slopes so we can really get that into that skin fold to work. And you can see the Convatec esteem body in the middle, which we are going to be showcasing at the NSWOC conference, and you guys are getting a sneak peek at it here. So more examples of the clinical application of the 5 characteristics of convexity that they use to create the esteem body. A proper clinical assessment of the patients that you see here will help determine the right amount of depth needed to achieve a good seal and prevent pressure injuries. And the use of soft and firm convex barriers depends on each individual stoma and abdominal topography and tone. So you can see here in the far left, the use of FEA has told us that the tension that we want for this person who has a slightly budded stoma that's in a soft abdomen with a deep fold, we're going to want that peripheral tension to move the skin fold out of the way. We're going to want deep convexity of 7 millimeters. We're going to want less compressibility because it's going to need to be stronger to move that skin fold out of the way. And we're going to need more of an angular slope due to the depth and the shape of the bowl that you can see that stoma is sitting in. In the middle of the screen, we have a firm abdomen with a flush stoma and creases at 3 and 9. And again, using what we know, we're going to use peripheral tension. We want that shallow depth. We want more compressibility, and we want a low angle of slope, again, so that we can fit the convexity into that unbudded stoma to get the best fit possible. And then on the far right, we have a flush stoma, yay, but it's in a soft abdomen with solid stool. So we're going to, because of where it is, we're going to want to use that central tension to really help the stoma pop out from that skin fold. We're going to use a deeper convexity, again, because it's kind of sitting in a bowl. We're going to want less compressibility, moderate flexibility, and again, less of an angle because it's not that deep. Too much convexity is never a good thing. We all know that we want to use the least amount of convexity for convexity safety. And we also know that even just using a belt with a firm system can increase forces on the abdomen, right? We can use convexity in the postoperative period, but we need to select products that exert the least amount of pressure on the mucocutaneous junction. Experts recommend achieving a seal to prevent leaks using convexity far outweigh the risk of injury, far outweigh the risks of skin injury. So, and if you do suspect skin injury from convexity, consider a wider convex diameter with decreased depth and more compressibility. On the bottom here, unfortunately, we can see someone that has experienced peristomal pressure injury. So here we're looking at compressibility again in its clinical application, and we're looking at soft convexity versus not compressible, which is more rigid. So on the far right there, we have a stoma with an opening at skin level. The abdomen's firm. So we're going to use central tension, shallow depth, and something easily compressible so that we can really get in there. The abdomen's firm, so we don't want to put too much pressure on it. And then on the far right, we have a person with a very soft abdomen with creases forming in the sitting position, which apparently you can't see in the photo. They have a budded stoma, but the os points down directly at skin level. So again, we're going to need to use something that we can really, that needs less compressible weight and we're going to use peripheral tension to prevent that crease formation that unfortunately we can't see in this photo. So in summary, there is a benefit of having a wide range of tension locations and depths that can help us find the right fit. One, we think of the 5 characteristics of convexity. It can be helpful to think of tension location and depths as ways to choose the correct pouching systems for our patients. We need to remember that the complication rates in the first 5 weeks after stoma surgery is 70% or more, with leaking and dehydration being our top concerns. The leaking is never normal and should be identified early to preserve skin health, and that assessments should include abdominal stoma and peristomal evaluations, and that we should use the 5 characteristics of convexity as a guide to selecting the appropriate products. And just a reminder that tension, location, and depth determine the amount of force applied to the tissue, and that tension location either helps to pop up the stoma or flatten it out. So again, we are looking at central tension if we want to pop out a stoma, or we are looking at peripheral outer to flatten out skin folds. So these are my references. And now I'm just going to give you a quick sneak peek at at the esteemed body that we are going to introduce during the NSWOC conference. This was created with the 5 characteristics of convexity that we talked about. So it combines leak defense, which is Convatec's gold standard of adhesives, with comprehensive soft convexity range. And it comes in both pouches that are closed for urostomy and colostomies. It has the colostomies have an H-shaped design. It's soft gray, and that color was tested under diverse skins, with the idea being that it was going to be the most discreet color possible when seen under a white shirt, even when it's wet. And again, it was tested on diverse skins, which is amazing. And it's got this cool H-shaped design that you can see on the bottom there. And that was created by some very smart scientists who figured out that when you use that H shape, it forces the effluent down into the bottom of the pouch so that you're not having pancaking up at the top. And the urostomy pouch has a chevron shape. And again, that's to force the urine to the bottom. And it's got a V for the backflow. And they all feature, again, the warm gray. And this was actually designed with the 5 characteristics of convexity in mind. They looked at the article and said, hey, let's create something that actually addresses those 5 characteristics that ostomy nurses are asking for. And it actually comes with 8 kinds of tension locations, 4 for peripheral and 4 for the central location. So this is really, I think, going to be a game changer for ostomates. And it also comes in closed end. And these are the sizes that it's available in. And if you have any questions about this, there's the 1-800 number that you can call to ask for free samples for your patients. But I think this is going to be very helpful to us to really custom design convexity. So I guess I'll stop sharing and we'll take some questions.
Thanks, Lori, for that incredible presentation. A great review and a great overview of what's to come. So that's amazing. I like the fact that you actually highlighted the 5 characteristics that should be considered when you are looking into the utilization of convexity. And you again raised the awareness amongst everybody about the common misunderstanding that the utilization of convexity should not be considered post-operatively because of former fears of complications related to mucocutaneous separation or even pressure injuries. So thank you for giving us some awareness about that one, and and also introducing some of the products that can potentially support and minimize those potential complications. So we do have a couple of questions here that I'm seeing. I'll start off from Amy Barg. She says, excellent presentation. Can you kindly address when you would consider using an ostomy belt with convexity?
I think that if you're trying to maximize, the benefits of convexity, I would then use a belt. It can also be used just to give your patients, a feeling of more confidence. The issue is that when people use it incorrectly, they wear it too tightly, or they think, oh, it's a belt, I need to wear it in my belt line. So we don't want, and when they do that, we all know it pulls the pouch up instead of in. So we need to remind people that you're probably going to have to readjust this belt several times a day, because if you feel your pouch being pulled up, you're wearing it wrong. You need to pull it. You need to position your belt so that it's pulling your pouch in. So I don't think there's a wrong time to wear it. There's a wrong way of wearing it.
And I think that's a very important point, Laura, that you mentioned, because the combination of the belt plus the rigidity of the actual ostomy flange itself can synergistically contribute to developing peristomal pressure injuries. So we have to be cognizant and be aware of how that interplay works, and the appropriate use of the product and how they're designed is very important in that context. So thank you for that. Now there's a question here, and I'm reading a lot of Joshua on the chat box because I've shared, I think, my link to everyone. And
Okay.
there's one here. I think you might have answered it, but it's probably good to kind of just review. How do you choose the right convexity with depth and plateau?
Okay, well, I'm going to answer that in light of what we were talking about with the types of convexity. If you are trying to, if you've got a well-butted stoma, but you have skin folds, then you're looking at peripheral tension. So peripheral meaning outside. So you're going to use a peripheral tension for moving the skin or preventing creases away from the stoma. Now, if you have, conversely, if you have a stoma that you need to pop out, you're going to want to have that central tension center around the stoma so that it focuses the pressure around the stoma to make it pop up. So when we think about tension location, the way it helps me is to remember where is the focus of my convexity? Because if you put, if you just, take a one size fits all convexity, where usually the convexity is just pressed around the stoma and you've got a great stoma, but you've got a skin fold, the skin folds is just going to pop that off because the tension location is not where you want it to be. So I guess my long-winded answer is to think about what are you trying to achieve and what tension location is going to give you the result that you want. And the great thing about, in the case of Convatec's latest line, that when I saw it, I thought, oh my God, angels are singing, was that because they have 4 peripheral tensions and 4 central tensions, you can actually, it's almost like designer convexity, where you can say, okay, I have this, so I need my tension closer, or I need my tension further away. So you're less likely to have pressure injuries, and you can really get convexity that is comfortable and works.
Thanks for that answer, Lori. Actually, there's a comment here from Carissa Lux. According to her, we are using a steam body in Manitoba and having excellent success.
Excellent. Excellent.
And so I'm just scrolling down here. Give me one moment.
Yeah, this was launched. It was actually launched a year ago in Italy, and they've had like phenomenal results. I remember when the article on the language of convexity came out, I thought, oh my God, that was the most amazing thing in the world. I thought, finally, someone gave me what I didn't know I needed, which was a language to talk about convexity. Because, if I'm talking to you and I'm going, the pressure here, and you're like, the pressure where? What are you talking about? And we're talking about different languages, and then you talk to your patients and you need a language that you talk to them about, and then they go and they go into a retailer and say, oh, I need convexity, and they're trying to explain to them convexity. Now we have like a language we can all talk about and say, oh, I get it now. So yeah, I've shared that article with everyone. So
Thanks, Laura, for that. And I think you hit another important point in there, is that using the same common language when we're trying to describe like convexity. And even in wounds itself, sometimes we're using terms that might not be even like clinically appropriate, but it would be good to actually utilize the right type of terminologies as we are documenting, so that we can see that across the board and people get to understand it. So there's a question here from Mary Davis. Can you verify if you are needing to offset, you cut hole of your base plate to avoid other adjacent structures on the abdomen that would otherwise fall under the flange and prevent adhesion of the flange to the skin? Are we to avoid using convexity, as this would change the pressure redistribution on the different areas of the skin, or can you still use it and cut the offset?
okay, that's that. Okay, it's a bit of a complicated answer. The short answer is yes, but you're gonna need to watch again, where's the tension location of your convexity landing? So you're gonna need to make sure that wherever that pressure is, when you offset it, that it is still within the parameters that that you want. I don't know if you've tried. Sometimes I've tried using a smaller flange so that I can really get the pressure where I want it to. But yes, I have offset it. And again, you just want to make sure that you pick a flange that gives you enough coverage of the area without putting pressure where you don't want it. So again, the short answer is yes. The long answer is be careful.
Thanks again for that, Lori. And I think that's a very important key point because it may alter the redistribution of pressure. And aside from leakage, it can cause damage too. So a couple of comments here from Anne-Marie Larocque. Fantastic presentation. Thank you. Kathy Summers says the same thing. Great presentation. Carly Lindsay also says the same thing and love having more options for convexity. Great presentation according to Rochelle Bose. Now there's a question here from Jane Rand and it says, what if you have a stoma retracted and also in the abdominal folds? And I think you might have answered this one before, but it was
that you might have to be trying a little bit of mix and match. And I think that is why convexity is so frustrating and challenging for people, because it's not 1 + 1 = 2. There's sometimes there's a lot of like tinkering involved. So if you have so now if we have, so we've got a retracted stoma and we have abdominal folds. In that case, what you might want to try is you could either try using something, a central location with one of the wider sets so that it's going to push out a little bit. Or conversely, you could also maybe try the peripheral with the smallest peripheral tension in the center to try and push stuff out. That you're going to have to try, and it would be either of those. But once you figure out, it will be beautiful. And again, it depends on, because you're saying the stoma is retracted and it's in an abdominal fold, how you need to figure out like how deep is that, and that's going to also determine what you're going to do. So you might, like I said, you might go to the far end of peripheral or the far end of central. And it's going to depend on, like I said, how deep is that bowl of convexity that it's sitting in. That's, I think, what helped determine that for me. But mostly it's going to be trial and error, but that's where I would go with.
Thanks, Lori. So Sakina Mohammed also says, excellent detailed presentation. Tom Chang did mention that super soft convexity works sometimes. As a comment, Jennifer Bilby also says, I like having the idea that we will be speaking the same language. Thanks for creating this resource. And Deanne Cholet also mentioned excellent presentation as well. Well, for me, what I love about your presentation, Lori, is one of the things that I always look into presentation is the utilization of theory into practice. And the framework that you have mentioned about knowledge to action, actually knowledge translation framework or knowledge mobilization framework really speaks out in your presentation. I love the fact that you actually showed us the science behind how these were developed, because it makes us understand how they're designed and how they will actually work in real life. And then to close that loop, you've showed us complex cases where that can be applied. So I really appreciate that you've done that, and an incredible work for that one. I really appreciate it. Thank you.
Yes, thank you. I really liked that they took theory and applied it to actual practice that we can use, and that whole FEA modeling, that they borrowed from pressure injury modeling and then applied it to convexity and stomas. I thought, oh my God, that makes so much sense. Why did somebody not do that before? Because we were always kind of guessing before. What if I go here? What if I go here? And now, to divide it into central and peripheral, I was like, wow, that just made, once I went through the whole process of, okay, how did we get here? Okay, we did modeling. It made so much sense. And as I said, I can just see this is going to be, so helpful to patients, and just convexity in general is going to be so helpful to our patients, especially with the fact that 50% of North Americans are obese. So we're going to need help with that.
Thanks, Lori. So there's another thing I want to kind of like ask. I might have missed it in one of your slides, but if our fellow NSWOCs and SWANs are utilizing Convatec's Ostomy line, particularly the convex ones, is there kind of like a decision tree that allows them to really that's kind of like tailored to the 5 characteristics as what you have mentioned, that allows them to kind of easily navigate through the appropriate products to use in certain situations?
No, there's not a decision tree yet, but thank you so much, Josh. I think I'm going to steal that and suggest that, because right now it's still a lot of trial and error, and we're trying to educate people about peripheral and central attention to help guide them that way. But if they ever have any questions, again, they can call our 1-800 number that I'm gonna put in the chat, because there are 3 nurses and an NSWOC that answer that phone Monday to Friday, 8 to 6 p.m. And you can talk to them clinician to clinician, and they will help you figure out what's best for your patient, and then they can try it before they buy it, because to figure out what the best, because like I said, we understand this is a new thing, so it's going to take a lot of education and trial and error. So we're willing to do that. So, but no, there's not a tree yet, but that is a fantastic idea.
That's awesome. It's all yours. And so again, there's people wanting to have the slides, but I know that we're recording this event. So for anybody who would like to review this, the sessions that we are posting, that we are providing today, you are more than welcome to actually go through our on-demand on NSWOC. So after the session, this will be all recorded. So are there any other questions for Lori at this time? I am not seeing anything in the chat, Q&A. So everybody greatly appreciate that, Lori. So thank you so much for your time on behalf of NSWOC Canada. Thank you for coming in today, and to Convatec for sponsoring this incredible and much important need of a talk this morning. Thank you.
You're welcome. Thank you for having me.
So at this time, it's already around 11:39 or close to 11:40. We can break for lunch at this time, but please be back around 12:05 so we can begin sharply at 12:15 for our next set of talks, and hope to see you guys again soon. Welcome back, everyone. Hope that you guys have a great lunch. There are a few things that I want to touch base with you before we proceed with this afternoon's agenda. One is that Lori just messaged on the chat box a link to the STEAM convexity selector, STEAM body convexity selector. So please check that out. It's not really a decision tree, but it is a tool that allows you to navigate through different situations that enables you to select the appropriate type of convexity there is. Now, Laura, there's a question there. I think you promised people that you're going to be sharing a 1-800 number
Oh my goodness, I'm just falling down everywhere today.
So I'll let you kind of like respond to that in a chat box. And as Laura is doing that, I also want to invite you on, if you're coming to our NSWOC conference, and I hope that you guys are coming to our NSWOC conference, because Laura is also going to do a talk there as being part of the panel on addressing healthcare inequities in the care of Black and brown skin. That's going to happen on the Friday of May 23rd. So please, you've heard how Lori did her presentation, very insightful, comprehensive. So please come on that session, please, and support Lori on that panel. And we will learn a lot from that one too, given that we've talked about different situations, the variance in skin tones, and this one around, it opens up more of the inequities that are happening in this type of population. Okay. So again, we're switching gears now, and I've invited a colleague of mine, an NSWOC colleague of mine working in acute care, and I want her to kind of do a talk for me about the impact of NSWOCs in acute care setting. But before I let Lee take over, I'm going to actually provide an introduction about who Lee Bateman is. So Lee's been a nurse for 35 years and holds a master in clinical science and wound healing degree. Nurses specialize in wound ostomy, continence, and in the IIWCC, or International Interprofessional Wound Care Course Certificate. Currently lead practices as an advanced practice nurse with a wound ostomy continence team at Niagara Health, where the prevention and early detection of pressure injuries drives her passion for change in practice. And again, the key word here is passion. And that's what we have seen from our speakers this morning. You can see how passionate they are in what they do, and I'm just loving it. So without further ado, over to Lee.
Hi, thanks so much, Josh, and thank you so much for the gracious invitation to speak today. I'm just going to start by sharing my screen.
Yep, you can see it
Perfect.
on the
Perfect. So when Josh asked me to speak today, I thought, what could I put together that would demonstrate or share with all of you what we're doing here at Niagara Health. And Deb Mings, who presented first today, she and I know each other quite well. And HHS being so close to Niagara Health, we quite often work in alignment with each other and collaborate with each other. So here at Niagara Health, we started a journey of prevention around pressure injuries. When I started here in 2022. So just to know, I don't have any disclosures before we do a dive into the journey here at Niagara Health. So just to give you a bit of an idea of what Niagara Health looks like collectively, we currently have 5 sites. We've got our St. Catharines site, which encompasses all of the care listed below. We have about 375 beds here. We've got our Niagara Falls site, which historically was known as G&G, for those of you familiar with Niagara Health. We kind of changed the branding of our sites a little bit to get away from more specific naming versus generalizing being that of the city that they're in. So we've got 235 beds over there. We do have some complex continuing care beds, ALC beds. Then we've got our Welland site with 152 beds. That's a little bit smaller, as you can see, than the Niagara Falls site. But all of these have an emergency department as well as an ICU. So really caring for those most acute patients. At our Welland site, we do have a complex continuing care area, the Wolcott wing. We then move on to our Port Colborne and Fort Erie sites. They have urgent care centers in them as well. They're a complex continuing care site. And just to note, we've got a south build that's well on its way. Anyone who's traveled through Niagara to Fort Erie, you'll see that construction there. To the right of you. So we're estimated to open up there in 2028 with 469 beds. So we're all incredibly excited about the south build. So this is sort of what my journey looked like when I started here. This was my first APN role in acute care. I had been an APN prior to coming here, but hadn't lived in that role in acute care before. So although I've spent my nursing career in acute care, I just hadn't practiced as an APN. So you can see a lot of fog ahead of the person in this slide. And that's sort of how I felt. I was on a road that I knew, really didn't know what was ahead of me. And I didn't know what I would come up against. So what I did identify very, very early on is that there was no doubt that there was very much a silo effect happening. And that's sort of how Josh and I connected quite early about me presenting today, is that we in healthcare, I think historically, really do practice in these silos. And I know we use the word a lot, and I really want you to think about what that looks like. I certainly did, which is why I took action in breaking down those walls so that I wasn't working in a silo, because not working in a silo was only going to do one thing, and that was going to benefit the patients at Niagara Health. I looked at our surfaces here at Niagara Health across all the sites and could see very clearly that we had a problem. We primarily had all foam under our patients, and that was an issue. So took a look at that as well. It was very clear to me early on that there was an organizational deficit. It wasn't just frontline not being able to identify what a pressure injury was, or the stage of a pressure injury, or pressure injury versus moisture-associated skin damage. It was at all levels. It was allied health, it was managers, directors, and even our CEO, who I've been so grateful to have quite a bit of dialogue with. And we'll talk just a little bit throughout this about how important getting that upper leadership buy-in to your plan, how vital that is. So in 2022, I embarked on that journey, and I started with the surfaces. So without having my role carved out as it is now, it was a fairly new role. So I started with an environmental scan. So I took an inventory. It was I went through a few pairs of shoes. So it was an environmental scan, again, at all 5 sites, looking at the stretcher surfaces, rather. And I did take note of what the condition of our frames, because that matters, as well as what were our patients on in the inpatient care areas. I looked at that, at those pieces, and put a data table together of what we had. I created a plan. I created a plan to get the foam out of Niagara Health. And you can see here that we implemented. So we went ahead and we implemented gel. We removed 80% of all the foam, and hybrids, meaning that foam mixture, if you will, and I won't name any of those surfaces because I don't want to, you know, for the respect of the companies. And then so removing 98% of all the foam off the stretchers was also something we were successful at doing. And why are stretchers so important? You know, some may think, well, why stretchers? Well, we all know why, because we're all in that field. Stretchers are important because we know that when we have busting of the seams at our organization, patients are on stretchers. We know that patients are in the emergency departments by far longer than we've ever seen historically. So stretchers are really quite important. So then we went ahead in 2023, and we continued the work around the surfaces. And one of the pieces of that environmental scan was our 3 ICUs with their, you know, PCU, SDU, like step down units that were associated to 2 of them. And then we have 1 ICU in Welland, which is just an ICU. It's got a tele close by, but the acute vented patients would never be out there. So I worked at standardizing those ICUs, because if you can believe it, we had foam and hybrids of a variation of brands of different vendors under our patients. So after so many years of nursing, I can't tell you how shocked I was to find that we had foam under vented patients. So that would be a problem. So we have successfully, since that time, in February of 2023, we fully standardized the Welland ICU with all owned air, which I'm so incredibly proud of. We just last week standardized the Niagara Falls ICU and step down unit with all owned air. And we probably, as we speak, have our last owned air coming across the loading dock here at the St. Catharines site. And all of this was made possible by a conversation with the CEO, who has made pressure injury prevention at Niagara Health a priority of our 5-year strategic plan. And I have full buy-in from her and the support behind her, or behind myself rather. We looked at creating champions. So in April of 2023, I developed an advanced wound education day that I'm so thrilled to say to date, I've had RPNs and RNs alike from all inpatient units, including our emergency department, although we wouldn't necessarily call it inpatient. There are admitted patients there, but we included all nurses across the disciplines or the specialties, from Emerge to our ICUs, our MedSurg, our complex continuing care, our mental health, our hemodialysis units. All nurses were welcome. And so again, to date, we've had 357 come through those sessions, and I am dependent on funding every year. So I usually find out around June what sort of funding I'll get, and then I go ahead and I release those dates. One other thing that I did early on is I developed a community of practice. And what I felt, to say that I was in that silo and I felt very isolated, is really quite an understatement. And I see some of my master's colleagues on the in the chat today, and so grateful to see your names there. But although we have all of these connections, when we're talking about real time and real action in our real working space, I think oftentimes can feel very alone. And how is it that we can move forward creating change without constantly going back to the drawing board and recreating, I know it's very cliche, recreating the wheel, but I think far too many of us do that. And I don't have enough time left in my career to get all the great work done that I want to get done if I'm constantly recreating the wheel. So I decided that I would develop a community of practice. This community of practice is a group of NSWOCs in acute care within Ontario. That was a starting point. There's always room to grow there. But currently we've got about 15 hospitals, acute care facilities that the NSWOCs and myself, we meet monthly for a touch point. We talk about it, and it's a very informal meeting. It's a very informal gathering, rather. We attend enough meetings, we attend enough spaces where there's minutes and agendas. We come to this touch point common place every month where we bring what we're struggling with. So what are our barriers? What are our wins? Who can help with what? Some of the hot topics last year for this COP was order sets, standardization, trialing different products, and just talking about how is one organization collecting pressure injury data versus another, and how can we support each other in our EPIC life, in our Cerner life, who's Cerner, who's EPIC. And so to say that we support each other is an understatement. And that hour is small in comparison to what we have available to us through each other and the resources that we can tap into via those in this community of practice group. When we have questions, when we want to do an environmental scan, which I quite often will tap into this group and I'll say, so who's got an order set? Or what surfaces do you have under your mental health patients? Just as a few examples. So the community of practice group is such an important part of the work that I do, because I am supported by those other experts in other areas of Ontario who are doing the same work or trying to do the same work and have the same struggles. So I can't stress enough how important it is to, if you aren't part of a community of practice, build one yourself. Build one yourself. Everyone on this call has resources, so I urge you to do that. The value is priceless. So I really wanted to showcase what we then did in 2024 with the successful branding of our pressure injury point prevalence team. This is at our Welland site. You can see that we've got red shirts that say PIPA. We've branded our quarterly audit as the pressure injury point prevalence audit. We perform this audit quarterly. So every March, every June, September, and December, we carry out our PIPA. The PIPA team in front of you is, most of these are standard within our quarterly audits. When we first started, my manager, who's right down there in the center, squatted down, bottom row, she's also an ICU nurse at HHS. So I'm really grateful to have Tanya as my manager. And so she brings a great lens. we do our quarterly PIPA and take that information back to the managers. So what was happening when she and I started about 6 weeks apart from each other. So we built this great PIPA team. And when we first started, we were trying to recruit. Now, we don't take part in the IPOPs, so we don't have any vendor influence, if you will. We developed our own form of data collection, and I would say at this point it's a well-oiled wheel, and we do it across all 5 sites over the Tuesday to the Thursday, and we've tweaked it a little bit as time has gone on, but we actually have a wait list for staff wanting to join our PIPA team. Branding ourselves with the t-shirts was something that I felt strongly about, and finally did get it after 2 years. What happened here is, one, when we were on the units performing our bedside audits, we weren't being asked by staff if we could give a hand. Not that we wouldn't give a hand. Let me clarify. We absolutely help when we're on the units. If we're assessing a patient, doing a bedside audit, skin assessment, and they need a brief change or they need a bedding change, we do that for them. But we were getting kind of caught up in the mix of what can sometimes be unit chaos, and we weren't easily identified. So we have our PIPA t-shirts. Now we're known as the red shirt team, the PIPA team. And when the unit sees us coming, they know who we are. They can ask us questions around pressure injury staging and pressure injury prevention. And each and every one of our PIPA staff are highly educated at this point with how to stage a pressure injury, how to differentiate between a PI and moisture-associated skin damage, and doing that education with the patient and the care providers, the loved ones, the family members, friends, who's ever at the bedside, and of course, staff. So this was a big success for us, and we're really very proud of it. So I wanted to showcase that work a little bit. Now, again, when we get our quarterly audit data, and I'm in the midst of doing it right now, I take those beautiful dashboards, they're laminated, colored dashboards. I set 30 minutes aside with every manager of every unit that we have audited, and I walk through their data with them. I walk through what their Braden completion rate was, how many happies they had over the last 4 quarters, and just doing that teaching of what is pressure injury prevention. The message I'm sending this audit is, some managers are kind of shocked at the happies that they have on their dashboards. And I'll remind them that that's not necessarily, and is quite likely not an accurate number, but rather I have to always remind managers, if your staff are not doing a head-to-toe skin assessment and documenting it, we have nothing more to go on than what is in the electronic chart. So please remind your staff to not only do that head-to-toe skin assessment, but be ensured that you chart it so that we can go back to that first skin assessment and say, the patient absolutely had a pressure injury on admission. This was not a happy. And without that information, we can only call it a happy. Somebody has to own it. So that's just ongoing work, but we're really proud of where we are with our PIPA. So again, we take our data collection and we share it. We share it with the managers. I attend huddles with Frontline, with Allied Health, and we then take that data and we put it into action. How do we do that? Well, when we recognize that, for example, we have, which we see every PIPA, less dietitians are being consulted when a patient has a pressure injury, stage 3 or greater. So we know that that's always work that we need to do. So we look at action points that we can take away from each PIPA to take back to a unit level. And those are just some numbers to share with you. You can see how high we were. That was overall. That was all of our pressure injuries, one right through to our unstageables and DTPIs. So you can see how we trended down with the changing of our surfaces, with standardizing education, providing the education, and equally important, having a PIPA team, people collecting professionals. We've got PSWs, we've got RPNs, we've got RNs, and they have become experts. They're not SWANs, they're not NSWOCs, they're frontline, who are part of a very passionate team at Niagara Health to prevent hospital-acquired pressure injuries. So some of our successes, of course, we standardized our inpatient surfaces, as well as, our MedSurg CCC, as well as well on our way with our ICU. I'm working on a foam-free policy, rather a surface policy that will encompass the language of being foam-free. Having now got the buy-in from procurement, leadership, no foam comes across the loading dock at Niagara Health. And if it does, it doesn't get very far through the door. Pressure injury steering committee is something that we breathe life back into in 2024. It's a huge success for us. This is an interdisciplinary team. We meet quarterly following the PIPA. We review the data. We look at Niagara Health on a whole, and we identify where there are gaps and look for the solutions with not just the lens of one discipline. It takes more than an NSWOC, right? We need our dietitians, we need our OTs, PTs, we have managers, we have patient partners. So this is very interdisciplinary. We have an increase in that staff knowledge. So again, those advanced wound education days have had 357 nurses come through those sessions, which are a full day, and they're marvelous. We have developed wound care champions from our nurses. We're doing a bit of a revamp on our wound care champions, so I won't speak too much to that, but the idea of our wound care champions really is at a unit level to support new staff, current staff, being that person who steps up and says, hey, you've got a VAC today, I know you're new, do you need any help with that VAC? I'm here to support you if you need me. And again, forming the connections through the community of practice with the acute care with NSWOCs to support those BPGs and that broader change. So what does 2025 and 2026 look like for Niagara Health? Well, I can say with certainty, I came through the front door of 2025 with a pitch for my manager and director that clearly, and I'd been watching for a little while, we were missing a very important role, a very important person on our interdisciplinary team, and that's our PSWs. So we are currently in the midst of, with a great deal of support, God bless Kathy Harley and Kim LeBlanc. So we are building skin health champions here at Niagara Health with the support of our PSWs. They are the team member that sees the skin the most. They see the skin first, and they, with an eye to recognize risk, in my opinion, can mitigate risk more than anybody else. So we're tapping into that, and maybe Josh will ask me back in a year and I can share how our skin health champions rollout went. But I have the greatest of faith that that is going to be a huge success. They are excited, they are passionate, and they go above and beyond. Our organizational community of practice is something that I'm also really excited for. Our director has taken this on, and she's in the stage of trying to connect with other organizations at a director level to talk about that benchmarking, to talk about those barriers, to talk about those wins, and how can, at a director level, can they support each other organizationally? Again, breaking down the walls. We are so here at Niagara Health about collaboration that it warms my heart that we now have a community of practice at that level of leadership. That's huge, in my opinion. It's huge. It means that I feel like I've been heard, and I'm so very grateful for those leaders at Niagara Health. We're going to continue that ICU surface standardization. Of course, we're not quite there. We've got those 8 beds that we're waiting on. One big thing that we are working on here at Niagara Health, and very transparent in saying that in the fiscal year of 2023 to 2024, we spent $1.2 million on rental surfaces. Ridiculous. There's a few issues there. One of them is accountability, and the other is lack of process. So with the standardization of the surfaces, we recognized, and also let me just back up, we introduced HIS last fall. So that brought a few obvious barriers to the rental surface process that we've had to pivot. But we've had a great support from Arjo, who is supporting us to move towards Arjo Express for the access of our rental surfaces. We've also recruited what we call a clinical scholar. She's a warrior to me. She's an RPN here at Niagara Health in a medical unit that we've had the blessing of having her for hopefully a little bit more than 3 months. And what she's doing is she's helping to develop that rental surface process as well. She reconciles our rental surfaces across all 5 sites every week. She does that comprehensive head to toe skin assessment on those patients who are on rental surfaces to discern whether they should be on that rental surface or not, and is doing the education with the staff in that moment on when we would use a rental surface and when we would not. And she uses our Niagara Health surface algorithm and surface selection guide to support that work. Order sets for pressure injuries and skin tears. This is something very much that our community of practice NSWOC in acute care in Ontario have talked about. I'm in the midst of working on mine, and when we meet next, when our COP meets next, of course, I'll bring that to this group and look for some support and some feedback. And one thing that I heard a lot this morning when Deb was presenting, as well as Shannon, is, talking about that moderate risk. We are hoping to launch a campaign here at Niagara Health where the moderate risk is the new high risk. And that's not to skew the lines where high risk lies, but rather to get staff to understand that, when someone's a high risk on the Braden scale, they likely already have a stage 1, 2, or worse. People who are in that moderate risk, that's that small window, right? And I think we could all agree that's a small window. And if we could just mitigate risk there, if we could get them on the right surface, if we could get them, get the dietitian involved, get the OTs and PTs. So just before I close, this is just a beautiful roadmap that we have used at our pressure injury steering committee to just show our roadmap of success. And you can see that we've partnered with those patients and families, and that is so very important to have the whole team as interdisciplinary, and not just those who get a paycheck from our organization, those who have other interests, like the common interest, the patient. So I want to thank everybody so very much. It has taken an absolute community to build what we are building here at Niagara Health, and we are just getting started. So I look forward to the opportunity to coming back and sharing some of the successes of our ongoing hard work. So I thank you.
Thanks, Lee, for that excellent presentation. And I could honestly say, I think from the comments that were on the chat box, you have just inspired a lot of our NSWOC and SWAN family here. And with the incredible work that you've done, that's such an incredible set of work that you are bringing a lot of that team members' efforts together to understand how important it is to really prevent pressure injuries. Now, your role, as I'm listening to you, thank you for representing NSWOC, in that context, because you are the cornerstone of your team. Without somebody who's taking on that leadership component, that leadership role, nothing's going to happen. It might just be an idea, but if no one's going to be pushing that forward, it's all just an idea, an abstract thought. But you made it all happen. Your advocacy work, from talking to the CEO and building it into as part of the strategic plan, is much, much important, because you have signed himself in there that he's part of the plan when you move forward with your plans and interventions. situations. And I like the fact that you also engage people from different levels of the organization, from the grassroots. I like that you involve the PSWs, healthcare aides, the nurses, RNs, and RPNs as part of your PIPA team, because again, they are the front lines that sees the patient's skin every single day. And there's no better team to be involved than those individuals that is part of that team, and the constant communication that happens amongst them to escalate situations along the way is so, so important. Now, the last thing I'm going to say, I guess, unless otherwise I think about something else, is I just want to put a plug out there that actually Lee is one of my inspiration that pushed me to actually engage more into the community of practice, because and I really encourage people to really look into the surveys later on after this session. Is we want to hear your thoughts, because as what Lee has established in acute care settings, it will be good to have different communities of practice and different sectors of care. We have talked about having these silos where there's different barriers out there, and even in our past Canadian pressure injury summit that we have held last November, one of the things that is lacking is standardization. We have great best practices out there, but what's happening is that they're not even being embedded into the practices in different organizations. And why is that? It's because all of us are practicing our own way, and we have to kind of start thinking the same way, practicing the same method, and also using the same terminologies of what we talked about, break down the barriers, identifying gaps, and by building all these expertise and then this community of practice, then hopefully in the future, that the ideal world that we are perceiving with pressure injury prevention and management is achieved. So with that worthy discussion, I actually want to just highlight some of the comments from our chat box here. And again, from Angela Legros, she says here that excellent advocacy. I want to take this and implement at our institution. So great work. Also, Cecilia mentioned that she has joined POSIC, but would love to have a community of practice in Canada. And Marie Larocque also mentioned that, knowledge is power for all care providers. We all need to break down the silo way of thinking, and we need to share more. Now, Carly loves the shirts, the Viva shirt. Probably you have to give some more ideas about the design of that. That's amazing. And Mavis mentioned also, Lee, well done. You are so passionate about what you do and are doing. Kudos to you. Again, more kudos from as well from Durrani as well. And also here, I'm just checking out the chat box. So great work from Marcy. Excellent work, Lee. Well done. According to Allison De Silva, I'm very appreciative that you developed the COP with NSWOCs. It helped me in my practice immensely. So these are excellent comments on the great work that you have done, Lee. So definitely you will be coming back for another session of our regional meeting. And I'm more than happy to always learn from and with our NSWOCs and SWAN colleagues such as yourselves. And so, yeah, thank you.
Thank you so much, Josh, and thank you, everybody.
Okay, so without further ado, we're going to move on to our agenda item now with a focus on continence. Before I pass it on to our next speaker, which will be Susan Chandler, I just want to highlight how creative her title would be for this focus session. It basically says here, hello, Incontinence Hotline, please hold. So I love that title. So before she starts, I just want to give a quick introduction about Susan Chandler. Susan is an RN and NSWOC with over 35 years of experience in both the United Kingdom and Canada. Qualifying in London, England, she spent 20 years working for the NHS before moving to Canada with her family for an adventure. Susan is a clinical nurse specialist for wound and ostomy care at North York General Hospital here in Toronto. Now over to Susan.
Mute. Hold on, I forgot to unmute. How silly was that? Okay, let me just go from the beginning. Thank you very much, Josh, for the introduction. And wow, the speakers today have been really inspirational. I've had to dip in and dip out, and I'm kicking myself, but I was late to the table, and so I didn't actually get the chance to take the day off. And you are all going to be a very hard act to follow. So what I'm looking at to do today is to talk about the non-medical management of incontinence. And here is the caveat. There are a lot of very experienced, very knowledgeable clinicians in this field. But you've got me today, so I'm going to suggest that you reach out to your subject matter experts locally, find out who they are, get them to, them to share their knowledge with you. I haven't actually put any objectives in here, but what I was hoping to do today was really look at an overview of incontinence. And pardon me if this is all a review and renewal, but I think sometimes it's good to just sort of go over the basics before we look at the second part of my talk, which will be looking at a incontinence management plan that we use here at North York in acute care. So I think when you actually ask an NSWOC about continence, I think the general feeling is, well, it's a C at the end of NSWOC for a reason. We don't do a lot of it. But in fact, we actually do, because it actually is the groundwork for most of our skincare. We're looking at moisture management in some form or another. And it's also surprising how many people are actually truly affected by issues with incontinence. It remains a taboo subject that people just do not talk about and therefore will not seek help for. When we look at the statistics, the urinary incontinence is seen at least 55% of nursing home residents. And this is 2019. I would imagine it's probably a little higher, but I hope all the SWANs and the NSWOCs out there are doing their darndest to correct that. Over 3.3 million Canadians experience at least one type of different incontinence. That's a huge amount of people. And again, that really speaks to the taboo issue of incontinence. It's also the second leading cause of institutionalization of older adults. And that was a really surprising statistic, although it's a little older. But if you think about how it does affect your independence, especially with functional incontinence and the risk of falls and just about skin damage, you can see how true that could easily become. And then there's a really nice study that came out from Shaw in 2020. It was of 1,000 people, 1,000 respondents, and they looked at having actual incidence of 23.7% of their study members actually had incontinence and identified with incontinence. So it's not a problem that is small, and it's not going to go away. So what is incontinence? When we look at it, we know that it's the uncontrolled leakage of urine. And today I'm really going to be focusing on urinary incontinence. I've only got a little while, and to be honest, it's going to be a flyby, as it were. And often incontinence is a symptom of wider health issues, urinary tract infections, constipation, but also challenges with general health issues, diabetes, stroke. So I'm going to deal with 3 types of potential urinary incontinence. There are others, but we're going to talk about these 3 because I think if we can look towards identifying a few, it does help us build on our knowledge base. So stress incontinence identified by the RNAO is the involuntary loss of urine due to a sudden increase in intra-abdominal pressure. And this usually comes about because of the abnormal descent of bladder neck and urethra, which is usually associated with poor pelvic muscle support. And it can be exhibited when someone lifts or they cough or they sneeze or they're running. And most people who've had babies probably wouldn't want to be on a trampoline at any one time. So that's your stress incontinence. The leakage volume is generally small unless it's combined with our urge incontinence. So urge incontinence is also known as overactive bladder. Again, this is the involuntary loss of urine. It occurs when there's a sudden compelling urge to urinate, and this cannot be postponed. It's go or not. And the leakage volume is usually medium to large. Often we have the feature of nocturia, so we need to get up in the middle of the night to go to the toilet. And it's caused by abnormal excitable bladder contractions as one of part of its components. Mixed incontinence is that combination of the stress and urge incontinence, so the involuntary loss of urine with urge and physical exertion. And finally, function incontinence. This is where there's a challenge to get to the bathroom. So that could be because people have got decreased mobility issues, cognition, recognizing that they need to get to the toilet, or maybe that there are actually challenges within their environment, so that the environment isn't ideal for them to toilet. They might need a handrail that isn't there. Their toilet seat is too low. They can't actually physically get their wheelchair through the bathroom doors. So all of these pieces make for functional incontinence. One of the important things to note is that urinary incontinence is not a normal part of aging. It's not a normal part of any lifestyle, and the underlying conditions really need to be addressed if we're going to do anything about it. The old adage, treat the cause, is so important. So we're looking at management of incontinence, or trying to aim for continence. So the RNAO, in their wonderful guideline, and which I've referenced at the end, actually recommends that we should be providing a focused initial incontinence assessment. But there are very few people that focus on incontinence as such, and so often these assessments don't fully happen. We'll often do a hit and miss, or we'll just treat the issue as it is when people present with the issue during, especially in acute care, while they're here. They're incontinent. Okay, let's fix it now. And then what's going to happen to them when they get home? So with the continence assessment, we really need to look about how long has the incontinence been occurring? Is it long-standing? Or perhaps it's acute. And if it's acute, is there a reason for that? Perhaps they have a urinary tract infection, or newly diagnosed diabetes, or something is happening to their general health that is challenging the continence issues. What symptoms are the individual experiencing? And this is really important to hear what people's own personal experiences are and how it changes their life, because that's going to have a huge influence on buy-in for any treatment or advice that may be given. And think about also, how are they currently managing their issue? Are they needing to wear pads for protection? Are they even using correct urine pads? It's amazing what people will use to try and manage continence, especially with the price of continence products being so high. So the baseline continence assessment should include a complete medical, surgical, neurological, obstetric, and mental health and social history. The reason for that is we can get really big clues as to why things may be happening. And it really does give us an idea, such as, have they had babies? Have they had previous pelvic surgery? Or perhaps they've had a recent hip fracture that's giving them some functional issues to get to the bathroom in time. We need to know all the medications they are prescribed, let's face it, including the over-the-counter and recreational. And also consider other pieces such as smoking and alcohol. Alcohol being a bladder irritant, and also smoking for the coughing, where it increases intra-abdominal pressure. Perhaps using a quality of life questionnaire. I haven't included one of those. I will find one and add it. But people's quality of life shouldn't be underestimated. What do they want out of life? Is it meeting their goals? Look at food and or fluid intake, and including the type and quantity. Remembering that with urinary incontinence, constipation can be a huge factor. So are they getting sufficient fiber? Are they having totally caffeinated drinks, such as tea, drinking chocolate, fizzy drinks? They all stimulate the bladder and exacerbate frequency, urgency, and nocturnal voiding. So consider that. Usually we'd like to do a dipstick analysis that usually works really well. Dipsticks don't seem to be around as much as they are. Certainly not in acute care. We always have to send out to the lab. But with any new patients or resident presenting with incontinence, a baseline urinalysis is really important to rule out the chance of infection, and also just to see what else is happening, because it will give things like the specific gravity to tell us whether they are sufficiently hydrated. And you can do that so much easier than doing a blood test initially. Post-residual, the post-void residual urine volume. We don't often do that, except when people are in are having challenges with urinating, but it is a useful tool, especially when you suspect bladder outlet obstruction or incomplete voids. People that need to reposition on the toilet or void after they voided, that secondary void, it's really important to identify what's happening there. Getting a vaginal, rectal, abdominal and neurological examinations can often be a challenge, especially in the community and long-term care, but they are something that, the family physician could do, nurse practitioners, but they should be only conducted by competent health professionals. Look at environmental factors too. Considering for functional incontinence, is the bed close to the toilet if they're slow to walk? Are they sharing a room with a partner at home and perhaps don't want to disturb them getting up? Is the height of their chair or their bed actually aids them to get up and get out of that? Or will they need some additional help or maybe a bed raising, especially in the community? We used to put beds on bricks and things like that to get them to the right stage so that they could actually get out of bed easily. Consider things like toilet seats. Now it's so much easier to buy toilet raisers or higher toilet seats, bed rails, and toilet rails, and make sure that they can get in and out and there isn't clutter. And also consider for those people, what might be a trip hazard. And then what we would like is a 3-day bladder and a 1-week bowel chart. This might not be possible if they are not able to complete it themselves, so you might have to complete an observational chart, but it really does give us a little more information. And I'll show you what I recommend for the bladder diary. It gives information about these the voiding patterns, but it also looks at the amount and types of drinks, and the types are really important. This identifies things that might be caffeinated or bladder irritants. It also tells us, are we drinking what we're voiding? Because that's a big thing. Maybe that, is their urine very concentrated and this adds to irritation, especially if they're not voiding very much. What sort of bowel movement? And the reason that we actually include a 1-week bowel diary is that not everyone poos every day. So getting a week gives us a chance for a little more of an assessment. What we also want people to do is try and answer whether they leak or whether they are desperate to get to the toilet and can't get there in time. That's really important because, as we talked about earlier, it tells us whether there might be either the stress incontinence from the leaking and the urge incontinence from that overactive bladder. Pelvic pain is also very important. So pelvic pain can come from urinary tract infections, but also in the menopausal woman through urethral and vaginal dryness that can be a real challenge and cause more irritation. With the bowel movement and leakage, trying to identify what sort of stool sample that they're actually producing. And so this particular stool chart from My Health Alberta does quite a nice description, although we as professionals use the Bristol stool chart, being able to describe to people, they might not understand that. So using terms like toothpaste-like, form but soft, or pebble-like is usually very useful. toileting strategies. One of the toileting strategies that we always advocate for is actually taking a patient to the toilet. Most people come into acute care, for the most part, able to walk to the toilet. And we still see an awful lot of people placed in briefs, in pull-ups. And what we want to consider is trying to get them to the toilet on a regular basis. So using strategies like prompted voiding can be helpful. Most people don't need that prompted voiding, but those with incontinence issues can really benefit from it because it can help to teach the recognition of bladder signals, and it can really help with those with cognitive impairment. So prompted verbal voiding would be, should we take you to the toilet now? Or perhaps let's go to the toilet before lunch. You can wash your hands and then you can have your lunch. Just to encourage and re-cue the individual into regular toileting routines. With scheduled toileting, we're toileting regardless of an individual's urge or sensation. And the idea is to prevent overfilling of the bladder, which might result in leakage. And so, again, this is really just prompting people to go on a regular basis. So you may start at a 2-hour interval and gradually increase by sort of 15-minute or 30-minute increments to try and extend the time that the bladder is full and try for them to recognize that they're getting symptoms of bladder fullness. And the idea is it's for those people who perhaps can't reach the toilet independently or that they have difficulty in recognizing the symptoms. So some people don't often feel that their bladder is full, either because of cognition or through lack of sort of sensation as they get older, but also just to try and educate them into the toileting. Be patient with any toileting strategies. Involve the team. Get families, get PSWs, get everyone involved in this, because these toileting strategies take time. They don't happen overnight. Success won't be immediate. Just as potty training a child or potty training a puppy, it does take time to get those results. So I would also like to talk about bladder training. There's lots of recommendations for the RNAO guidelines about why it's important. And so one of those pieces is to, let me go on, to look at lifestyle modifications when you're bladder training. So this would be managing your fluid intake. So making sure that you have 6 to 8 glasses of water, which is about 1.6 liters as identified by NICE. And also reducing those fluids again with the irritants, the caffeines or and the fizzy pops, high sugars. Manage weight control. When we're overweight, we have increased intra-abdominal pressure, and also it can affect us functionally to get to the toilet. So keeping our weight well managed. Managing bowels, really important. Constipation is one of the biggest factors when we have incontinence. So please ensure that you've got a good bowel regime, encouraging fiber, encouraging lots of fluids. Smoking cessation, again, also not only an irritant, but also for the coughing piece that increases intra-abdominal pressure. And then they recommend the supervised pelvic floor muscle training. The supervision is really important to identify the correct muscles, and especially those people that might not be actually managing to identify muscles that would help. Again, this piece takes time. This isn't an overnight success. What I also wanted to talk about was the management of incontinence-associated dermatitis. In acute care, we see a lot of patients coming through following falls in the home, where they've been on the floor for a long time, and their skin is almost flayed alive. And this is because the urine stool actually, certainly the the urea in the urine actually is converted into ammonia. And so this really changes the acidic mantle of the skin that is naturally there, and changes it to a more normal pH, sort of a neutral pH. And this allows commensal bacteria to really take hold. So not only are you getting the ammonia sort of corrosiveness of the urine, but you're also having a higher risk of getting the coliform bacteria from bowels and other fungal infections such as the candida really taking hold. So it's really, really important to ensure that the skin is really cleansed well, especially from things like stool enzymes, because those stool enzymes in liquid stool are high, the levels are high, and they become very corrosive. So what determines incontinence-associated dermatitis severity? So the irritant that's involved, is it stool, is it urine, was it over a long period of time? And how often is the skin exposed? Was it a one-off where someone had had a fall and become contaminated with stool and urine, or is this something that's a regular occurrence? And your treatment regime may actually differ depending on how the duration of exposure and how often the skin is exposed. The areas exposed are often perineum, the labial folds in women, the thigh. You can go to the upper back, lower back, and it can cause increased discomfort, pain, and make people prone to secondary infections. And in the extreme cases, can cause swelling and blister formation. Consider that some degree of skin damage can also happen purely from fungal infections, and incontinence-associated dermatitis can often be caused by a fungal skin infection. Often the patient or client will present with IAD first, and of course that nice warm moist area in the dark produces a perfect environment for the fungus to grow. They're often scaly, the fungal infections, with areas of dryness, itchiness, and they spread beyond the area of moisture contact. And you can see these sort of lovely how to describe them, these sort of roundish lines, and you can see quite distinct patches. Here, consider the use of antifungal creams and powders. But in fact, we here at North York, we've been using the solution VASH as soaks with really good results. And this really helps us because it allows barrier creams to be put on for protection, which is often a little harder when you're adding antifungal creams and powders. So having a 15-minute VASH soak on the skin has really made quite a difference. And we use that after cleansing with a solution of perhaps one of the pH balanced skin cleansers, of which I'll talk about more in a minute. I should add that I have no affiliations and no disclosures. I'm just going on the products that we currently use. I have shown exactly what the products are that we use, but other products are available and equally as good. Incontinence-associated dermatitis should be a team approach. We should get everyone involved, making sure people are getting adequate nutrition, down to the person that delivers the meals and takes away the empty tray, to the person that's cleaning the bathroom, that if they're seeing a lot more incontinence on the floor, and people are not getting there in time, staff need to be made aware. We need to consider, everyone becoming involved, because this can make such a difference and make it less of a taboo. We need to treat the cause. So assess and treat the causes of incontinence, be it that they can't get to the bathroom in time, or perhaps they have a urinary tract infection, or there are other pieces that are causing this incontinence. skincare and fluids and nutrition are really important, making sure that they get adequate hydration and making sure they get adequate nutrition to help with healing. We're going to want to clean with pH neutral cleansers. Cleansing with just water alone will not remove the alkali or the ammonia from urine or the fecal enzymes. Soap will cause the skin to become more pH neutral, and we want to maintain that acidic mantle of the skin. So cleansing with pH neutral cleansers will really encourage that acid mantle to be maintained. Encouraging fluids not just to keep everything homeostasis in the body going, but also to dilute the urine concentration. It's going to make it less irritant. And then toileting. Quite frankly, why not? We should be getting people to the toilet. And we should be building that into our care plans. It shouldn't even need to be built into our care plans. It should be a no-brainer. And if this is not really possible, think about using containment products, but maybe only at night time. Perhaps if they're not able to get up in the middle of the night because they get discombobulated, perhaps they can be toileted during the day. If they need a bit more sleep, then a containment product. And obviously not double briefing. So I'd like to talk about the products here that we use here in acute care at North York. And I'd like to give a big shout out to my colleagues, Brittany Button, Penny Duretney, who really helped to bring this sort of overview to you. It works incredibly well. Our staff have all these products on the shelves. We're very lucky here that we do have them. And these products have been chosen just because they're available. Other products are available. Our staff know them well, though, and know which ones to reach for. And I think that importance and familiarity with products is really important. Just like you would never give a medicine without knowing what it does, you shouldn't be using anything on the skin unless you really know how it works and what it does, because then you're going to get the best results. So we use the Baza cleanser, and we use that only on intact skin to cleanse and also to protect. Once we start getting broken skin, we start using the Sprome and the Criticade, and we also have at we are also able to access the Cavalon and the Cavalon Advanced Skin Protectant. So we actually have built a little mnemonic that is actually as an order set within our nursing notes that we use, and also the physicians use regularly. And we use the Ghent Global IAD monitoring tool. So with a patient with no open skin, no infection, we will use this Sprome to neutralize the skin, and then we'll use the Baza Clean and Protect to moisturize and also provide that barrier. But the skin must be intact. Using Baza on in a broken skin can be very uncomfortable. So we really have to be sure that we identify the skin breaks very quickly. If we have a patient with category 1B, so there's no open skin, but we have a fungal infection, we will use a Sprome cleanser to neutralize any ammonia in the skin or any fecal enzymes and dry well. And then we will add a VASH soak for 15 minutes. We'll leave that on the skin, the affected skin, remove it and then pat dry, and then apply the Baza Clean and Protect. We use that as a first line over clotrimoxazole creams or powders, simply because it's a simpler process. Staff can access it on the carts, and that means that they can get on with the treatment. And as I said before, it also aligns quite well with the products we use, in as much as they can be put on and the barrier works well after a VASH soak. When we have no open skin, skin is broken, there's infection, there's no infection in category 2A, we then continue to use a Sprome to cleanse the skin, but we also add the Criticade Clear Barrier Cream. This this particular cream comes with a cellulose in it that acts almost like a moisture attractant, so it allows the cream to bond to the skin really nicely. Often we will use it in really extreme cases with the Cavalon Advance prior, and we will treat the skin maybe every 2 to 3 days, and no more, because we find we get a build-up of product. Once the Cavalon Advance has been applied, we always put a caveat that skin folds must be always held apart until it dries. We don't want anyone stuck together. And then we will apply Critic-Aid Clear 3 times a day. When we have the broken skin and fungal infection, we will do a similar sort of treatment as before with the fungal infections, again with the VASH soaks, but using the Critic-Aid Clear, which seems to be a better barrier on broken skin, and obviously more compatible and much more comfortable than using Baza. Okay. So with our continent clients, we toilet them regularly. I say that with passion. I would like to think we toilet them regularly. We have still a lot of work to do. It's, with time constraints on units, we understand things are a challenge and it's so much easier to put a brief on. But what we would like to do is get those people toileted. We do have good toileting facilities. We do have commodes, and we do try and encourage the use of toileting wherever possible. For our incontinent clients, we limit briefs. And that's not that we only give them one every 24 hours. It's that we would maybe choose to, when we use them, perhaps when they are ambulating, we'll put them in a pull-up. And then if they're not ambulating or they're bedbound, we will just use the Ultrasorb pad underneath, the large white absorbent draw sheet, and use that with one of our containment products, which I will talk about in a minute. We discourage very strongly double briefing and double stuffing with white pads because of the damage that cause to tissue breakdown. We've just done our IPUP study, and I'm waiting with bated breath to make sure that the double briefing is not occurring on any units. Watch this space. No hospital is perfect. We're trying for it, but it's hard work. The prevention of IAD for fecal containment. We usually will use an Ultrasorb pad. You notice the asterisks after a fecal management device. We try not to use them very carefully because of the risk of damage to the anal tone. And so we will often use them for a patient in ICU when we're challenged with being able to reposition them because of their general condition. But that will usually be the only time we will try and use them. And using just the Ultrasorb pad and our skin regime. With the urine containment, if it's not related to retention, we'll use the male or female external urine catheters, which I will show you shortly. And if it's used, if the urinary incontinence is related to retention, i.e. it's overflow, then we will refer to our urinary retention protocol. So this is a little overview of how we actually we manage with our prevention. So our ideal is to go briefless. At the moment, we are briefless in ICU, and some of the units, and certainly units where they identify patients as having urinary issues. Sometimes staff need to be reminded that, that we are going briefless, but for the most part, it's fairly well followed. We always consider if the Braden scale is 2 or less, we would put them on one of our air surfaces because of the risk of moisture damage as a risk factor for pressure damage. And again, putting in the 2-hourly repositioning. We would also, for the fecal incontinence, look at and urinary incontinence, looking at addressing the contributing factors. Is it constipation overflow? Is it C. diff? Is it because of tube feeds? And then we would get our dietitians involved to look at alternative feeds maybe that might help to solidify the stool a little more. So these are the external femoral catheters we're currently using. We use the PureWick system. It works with wall suction, but you'll also see the little portable device. And some patients are luckily in the financial situation to actually use this system when they are discharged home. We always have the caveat, we have a conversation with both the patient and the family about this, if that's appropriate to speak to the family, because external catheters aren't for everyone. They only really work for patients that are bedbound. They're certainly a trip hazard otherwise. And so, but they can be a very useful way of modifying risk factor for skin damage. So we attach them to wall suction and run them at 40 millimeters of mercury. These PureWick catheters are replaced every 8 to 12 hours and always when soiled. No brief is worn, but the patients are placed on an ultrazord pad. This is an item, again, we're lucky enough to have on our carts that nurses can start straight away if they identify incontinence as an issue. They want to get their patient briefless, they want to manage the skin, and they will instigate that. In addition, we're just about to onboard external catheters, again, a PureWick system, rather like a sort of a stoma bag into which the penis fits. We do use condom catheters, but sometimes in our older gentlemen or our larger gentleman population, their penile shaft length isn't sufficient to keep a condom catheter on. So again, we're looking at ways of managing continence, again, more for the bedfast patient. But these can be very useful. With this system, you actually change it once every 24 hours. There is the additional thing that pubic hair, because it's an adhesive solution that sits around the base of the penis, pubic hair does have to be clipped. So we have actually, we're in the process of purchasing clippers with individual single patient use heads for this. This is just about to come to us. It's quite a new system in Canada, so we're just looking to get that onboarded. And that was due to really finding that the condom catheters weren't always meeting the need. They're great if people are mobile and they have the shaft length, but we find with a lot of our patient population, they just don't stay on quite as well as they could. And when we want to keep them briefless, that's what our ideal is. So thank you. I would be happy to take any questions. Please let me know.
Thanks, Susan. You did mention that you're going to be reviewing continence management, but that's actually a comprehensive review of assessment and even like recommendations for management. And I liked how you touch base with the different types of incontinence that our client population and patient population are experiencing, and that you actually touch base in one of the things that is so close to me, which is basically incontinence associated dermatitis. Now, there is a question on the chat on the box here that is being asked by Cecilia Young, and it says related to the female external urinary management device. I think Brittany presented it previously. Suzanne, could you kindly share the protocol with us? So the question is, are you willing to share the protocol with any of our NSWOC?
Yes, my email's there. Please pop me an email and we'll share. It's very straightforward. The protocol is, providing they are not having a retention issues and the true reason for the incontinence has been established, we will pop them into an incontinence management system. Obviously, as I said, this isn't for those mobile patients. This is really for the bedbound population. But that could be a transient issue if they're coming out of, say, ICU, or they're just, prior to rehab or whatever.
Thanks
but
for
by all
that,
means, I would.
Susan. And I like how you kind of like leverage the utilization of the categorization tool, which is the Globe BIED, and see how that can be that can allow clinicians to really focus their approach on how to manage it. I mean, in practice also, I use hypochlorous acid also for my moisture dermatitis, and it works really, really well for me because the thing is, in essence, as much as possible, I want to avoid utilization of antifungals or even topical steroid creams because it results in the skin atrophy, which further increases the risk of erosions over time. So I find that using hypochlorous acid, given its slightly acidic state and close to the pH of the skin, kind of help promote healing of the skin a lot faster for us, while being also not only an antibacterial, but also an antifungal agent. It actually works really well. Now, a follow-up question to that, have you seen any, given that it's a soaking method, have you seen any increase in maceration at your end
Not
for
at all. And in
dermatitis?
fact, when you think about using it as a wound product, we don't see the maceration on the skin, even when we're packing those wounds with hypochlorous acid. So I think, remember that we're soaking just for 15 minutes. We're drying well. What it's basically doing is restoring the acidic pH of the skin, and giving it a deeper clean, because often these patients will not want to have their skin cleansed. It's painful. A cooling soak where you're putting soft gauze onto their skin, onto the damaged skin, can be really therapeutic as well.
Thanks for that, Susan. Also, the other thing that I like that you mentioned here is because there are a couple of pet peeves that I have when it comes to continence management. And one is, you did mention that is double briefing. Actually, let's backtrack a little bit. Let's backtrack a little bit here. So the first thing is that there's always this misunderstanding that as soon as a person enters a healthcare facility, that they are entitled to wear a brief. That's the first step. And I think that's something that us NSWOCs and SWANs should be really, educate people, is that, you know what, that is not kind of like a parameter for us to really consider every time somebody comes in. Because at the end of the day, we're not going to be here to promote someone's incontinence, but rather promote their level of continence. And unfortunately, there are times that I've seen in practice that we are often and when I say we, as as healthcare providers, we often encourage people to develop functional incontinence. There are times that I've seen in practice and I've heard like some of the frontline clinicians would say, "Oh, you have a brief on, you know what? Just do your thing on there, and then we'll come back and clean you up." But that's not
So
really.
those staff are taken out and shot, quite frankly.
So when I hear that, I was like, oh my goodness. So those things are really some of the things that we really have to reinforce, that, you know what, if you're asking people to really use the brief as a way to really, provide some level of, bowel or urinary excretion, you're just promoting the likelihood of one, infection, the other likelihood of incontinence, dermatitis, and fungal infection. At the same time, promoting more incontinence, as the patient or client will become more reliant in using these products.
I think one of the challenges as well is when people come into acute care, they're often given a gown and it opens at the back. So we make sure that they have a gown that they use as a gown, so like a dressing gown to cover the back. But also we have net knickers that they're not as dignified, but we encourage people to use those to keep their bottoms covered so that they're not walking around. And I think, a lot of times, especially with our aged population, they don't like the idea of having a bare bottom in bed. So, but we go at great lengths to explain why, and have things to help them get dressed to physically walk, to, get up and walk, to try and alleviate that. But as you say, a lot of patients do come in and do expect everything to be done for them, including putting in a brief. Yeah.
And thanks for that,
And again,
Susan.
that goes back to education.
Exactly, and that's what of our couple of our colleagues are mentioning here from Deraney as well as Mavis, that there's a lot of education gaps, and sometimes even if these gaps are recurrent, we still have to keep on reinforcing this amongst our colleagues and even the patient and family, essential caregivers that are present as well. Now, there's one thing here that I actually want to highlight that was mentioned before, but I lose track of that.
One of the things, while you're looking for that, one of the
Yeah.
things I do is when we have orientation with the double briefing piece to discourage people using it, I actually use zinc cream on my hand and put it on a brief, because actually if you use too much cream, you get the cream transferring onto a brief and you won't get the absorption. I then use colored water to pour it on to show where it's not absorbed. And that's a really good teaching method. The other thing is to actually use the double brief and say, look, you can't physically have the urine pass through the plastic layer. So why are you double briefing in the first place? All it's doing is making a nice little hot environment for all those candida to grow. So, and sometimes those visual clues can really help.
And thanks for bringing that up. And the other thing too, you mentioned, Susan, that you sometimes put patients on an air surface, and sometimes some of these surfaces have low air loss capability. And sometimes you
Yes.
wonder how come they're not working. It's because there's just so much layers of linen, including the brief, that increases humidity. And so it
Yes.
adds up to the likelihood of increasing risk, not only of moisture dermatitis, but also pressure injuries.
So no patient on a low air loss surface is in a brief. It's an ultrasorb or dry flow only and a sheet. That's all.
That's amazing. So Susan, can you do me a favor and put your email on the chat box? As people have been
Yes,
asking
I
me
will.
about it. And
I will.
think
I
we're
put
gonna
it
be
on the
reaching
end of
out to
my
you.
slides, but I've taken my slides down. So let me just get that down.
Okay,
And
as you
then
were doing that, I'm
I'm
just gonna
happy to
encourage
field conversations.
everyone to kind of please send your questions to Susan. We still have time. So I'm just gonna read through this. As you were presenting, Susan, there's like a lot of hand thumbs up, clapping, as well as hearts flying all throughout my page here. So excellent presentation. Anne-Marie said, great presentation, and thank you for that. And I think, you have inspired again in terms of continence management and assessment. So, a lot of our NSWOC and SWAN colleagues that are attending today, and hopefully those people that didn't get a chance to attend today's session, and we understand that because of people's availability, when they do watch these sessions, I'm pretty sure they're going to pick up on a couple of things that they can incorporate as part of their ongoing practice as well.
And remember, doing bladder training, it's not a quick process. Slow and steady wins the race. So sometimes you can only make little changes. And if the only little change is that you get your patient to the toilet during the daytime, that's a huge improvement.
Thanks, Susan. I think there's one last question that I have for you, because I was reading through one of the comments from, I think, Mavis, if I'm not mistaken, that, PureWake is a great product. I wish if all hospitals would incorporate in their care for the appropriate clients. I think the perspective is that it's a great tool to have. Now,
It is a great tool, and it's not for everyone. We did do a cost benefit analysis on it. And yes, it is a little more expensive than using briefs, but not as expensive as treating continence associated dermatitis. So there you go. You just have to make your case for it.
Thanks, Susan. And again, like similar to how we're trying to prevent, treat versus prevent pressure injuries, there are things that are intangible that are cost that actually affects the entire cost, such as nursing time
Exactly.
and your patient, comfort and quality of life that cannot really be quantified, but then does have a massive impact on the person and the healthcare system. Now, Laurie has a question here. Susan, do you have any more suggestions for encouraging patients to be more independent when they have taught to be incontinent?
I think just going back to basics and just trying to encourage them to go to the toilet. And then if you're doing regular toileting and rather than in a brief, they've got a pull up and that brief is consistently dry, then over time, you could probably move them into ordinary underwear. But again, it's that time and having that dedication and having that whole team aspect of really promoting the continence piece. But I think if you start off small, you get them to the toilet, even wearing a pull up, and you see a change and they're not getting through those pull ups, then the question needs to, well, why are you wearing a pull up? You're dry. I've lost you. You're on mute, Josh.
Thanks for that, Susan. So from Emily Ross, there's a question here about products your facility uses. Can a product like Biomic Pure Cleanse Hypochlorous Acid be used instead of VASH if the concentration is the same?
Well, I think you need to look at the product and see whether it works for your situation. We did extensive testing here to see what would work for us, size-wise on the carts, availability on the carts, and if you can buy small bottles that can be individual patient use, because you have to think about the infection control piece. So absolutely investigate it, but like everything, it's not a one size fits all solution. This is what we use here. I've worked in lots of places. Everywhere uses different things. Make it work for you. I'm hoping what this will do is just garner some interest and try and get people to think out the box a little bit more with incontinence.
And that's a really great point that you mentioned that, Susan, because again, hypochlorous is not really solely between, if you go across the global scheme of things, there are other companies that are providing hypochlorous acid.
Yeah.
So what's important for us to do is really do a kind of like a critical evaluation of how the products, and if, as what Susan has mentioned, if it's meeting the patient population that we're serving, and then it's working the way that the product is designed for the right reasons and the outcomes that we expect, then that's something that is worth exploring and considering too. Okay, so that was an excellent presentation, Susan. And I just want to say and tell everyone, I had requested Susan to talk to them, and I've kind of given her a very short notice. So I really want to appreciate Susan's time and commitment, and as she indulged me in today's session. So greatly appreciate that, Susan, and looking forward to more talks with you. And I look forward to working with you closely with our MASD panel. And yeah, thank you so much.
Thank you. It's been an absolute pleasure. Have a wonderful day for everyone else. Thank you. Take care.
Thank you. So before we go on to Sharon this afternoon, we still have about 5 minutes of our time. I know that people might need some bio break. Can we just provide like 5 minutes for people to do a quick bio break, and please have hop back on board so we can start at 1:45 for our next session. Thank you. Okay, welcome back, everyone. So let's switch gears again and highlight the role and leverage the role of SWANs, as I've requested my colleague Sharon Hunter to speak with us this afternoon. And she's going to be talking to us about the important and crucial role of SWANs in supporting transitions in care. But before she proceeds, I actually would like to introduce Sharon formally. Sharon has been an RPN for over 15 years, working primarily in community nursing. Sharon currently works in the Transitions Program for St. Elizabeth Health. She is the current SWAN Director on the NSWOC board, focusing on creating awareness and supporting utilization of skin wellness associate nurses across Canada. So without further ado, over to Sharon.
Thank you. Did my screen share okay, Joshua?
I don't see your screen right now, Sharon. Can you try it again?
Yep. Oh, it helps. Here we go. That should do it.
Yep, I can see it from my end. Thank you.
Oh, how do I hide those slides?
So you can click on the slideshow on the upper, yep, just above that, go top.
There we go. That looks familiar to me.
There we go.
I'm really pleased to be able to participate today, and I've been a RPN in Ontario home care for my entire career. I have had other roles in other places, but I almost always have had a role inside home care. And I recently, I think the first time was in 2023, I joined a transitional care team. So I just want to talk to you today about the impact of the SWAN and the transitional care team. But I also think you're going to hear how the transitional care team has impacted me as a SWAN and helped for me to grow. So a transitions program is an interprofessional team that provides a short-term 16-week hospital-to-home restorative care program. I currently work in the Georgian Bay General Hospital catchment area. It is filled with little rural towns that are along Georgian Bay, such as Midland, Pentanguishene, Victoria Harbor, and Wabashene. I work for SE Health. They're the provider agency for this program. So different transitional care programs in Ontario will be offered through different home care agency providers. And all of our patients that we're taking on have restorative or rehabilitation goals, and they're coming directly from the hospital. They're medically stable patients who, as I say, are ready for hospital discharge. They often are people who have come into hospital post-fall, who have experienced a fracture or may have experienced a fracture. They may have gone to the hospital because of deconditioning or weakness. They could be recovering from acute medical needs and events such as COVID, pneumonia, strokes, or heart attacks. It could be a flare of a chronic condition that's put them into the hospital. COPD and CHF are common. All of these patients, though, have come to the hospital with this acute medical condition. Usually before that, they were living independently in their home with their spouse, their family. Some of them, of course, live alone. And they were completing all of their ADLs and IADLs independently without needing any kind of support. So all of these patients that are coming out to us usually require 2 or more interprofessional services. Often, they always start with nursing for an initial visit, and they almost always have a physiotherapy goal involved in their care plan. All of the patients are facing a change in independence and or mobility. It's a big kind of pivotal change for most of them in their life. The age range of our patients as well have been as young as 20. And I think as old right now as 93 is the oldest person we have on service. That's the age range we have. Of course, lower limb edema is common due to the decrease in mobility and activity for these patients. There's a lot of mobility related incontinence or functional or disability related incontinence and constipation concerns. We do see a high number of patients that did not experience incontinence until they've gone to the hospital and had kind of this life-changing event, and now they're coming home with a higher instances of incontinence and things that if we are there to support them, we can help them correct and go back to being fully continent and independent again. And a lot of these patients are at risk for skin breakdown, pressure injuries, skin tears, moisture-associated skin damages. And I think looking at the presentations today, as we were going through, and I was listening to other clinicians' experience, I was thinking all of these things that we run into or see in our patients have been touched on today. And when I was preparing this presentation, I was thinking about, kind of the messaging and the impact that the SWAN has in interacting with these patients. And I think it's basically collectively, we're seeing a group of patients that really are just maybe sometimes at the beginning of this life change where their skin health is impacted, their continence has been impacted. They're fully functional adults who, weren't worried about a pressure injury. They were kind of worried about the cost of groceries and, how busy the grocery store was going to be last Friday. And now they're at home and they're not moving around as well. They can't, get up to go to the bathroom the way that they were before. And, they're feeling, soreness in their coccyx that they've never felt before and don't really know what's happening. And I think that's the beginning start where having a SWAN as part of this interprofessional team is really important. So the purpose of the program, of course, is to support these patients to return to independence in their home. With family, community, and private resources if they're required. There is a primary nurse, as I said, that becomes the lead clinician to meet and assess each patient and set individualized goal with the patient and the caregivers for the time during our program. This is another really important piece of our program. And this is where we differ from mainstream home care. When our patients are coming home, we have lengthy admission kind of visits with them where we're honestly able to determine what their goal for care is. So they all come and have their medical history and they have a diagnosis and they may have had a hip repair and have, require a dressing change to their right hip. That's often kind of the least of my concern when I come through the door and meet the patient. Sometimes it's the patient's concern. They think the nurse is here, she's here to change the bandage. And I think one of the things we're able to do, even in this first interaction, is to be able to show the patients that the nurse is not just here to be able to perform a task. The nurse is here to be able to get to know you, to be able to determine what your goals are and what your needs are, and to be able to show up for each of these visits. and help you be able to reach your goals. Our physiotherapist meets with each patient to assess and implement a home therapy plan. Our team consists of personal support workers, physiotherapy assistants, an occupational therapist, social work, registered dietitian, speech language pathologist, NSWOC, and spiritual care. All of these professionals are available to every client that comes on our service. I think the uniqueness, again, with the transitional care is that all of these services are available right away. There's not a referral process. There's not a wait time. There is, there's a direct communication with these people, and the most urgent services are able to get to the patient as quickly, as they're needed. So if I work with a patient who comes home and they're a new diabetic patient who's trying to understand their nutritional needs and be able to understand their insulin, we're able to work with them quickly to have the dietitian connect in to be able to review, what they're eating each day, to talk to them about doing, writing down what their intake is, and, working with the nurse and the primary care provider to be able to look at, how that insulin use is going, what the blood sugar looks like. And then I'm going to get into where, being a SWAN comes into, of course, on top of that. Our service levels often begin high, and then the patients transition to independence or a low-level support through our program. Some of our patients will go on to needing more support through Ontario Health at Home at the end of 16 weeks, but we do have a really high rate of patients transitioning back to independent with community services and family support or private support in their home. So the team impact, the joy of this program is that we have the time with all of our patients, and we have the autonomy as professionals. So my initial visit maybe takes 2 hours. I've had initial visits that have taken 4 hours in more complex cases. And there's no push in the design of the program for me to feel overwhelmed or that I need to, I need to leave, or the patient ever has any inkling that I have more things to do in my day. And that's really important to me as a clinician. Having the autonomy, though, means that at each visit, I can use the knowledge, skill, and judgment I've acquired as a SWAN to be able to address, other goals of care that perhaps my generalist nurse colleagues haven't got to yet. I will say one of my roles is, mentoring and guiding the other members of our team to be able to recognize and to be able to provide intervention for a lot of different things. And I think we do work as a very integrated team. So there's a lot of things that my team has already caught or has begun to do some teaching on before I get there. But when I go to meet these patients for the first time, if they're a diabetic, I'm able to, take their socks and shoes off. I have that. Every patient takes their socks and shoes off. In fact, most of my patients see a Doppler within the first 3 days of service, just because there's no reason, when I have the time and the autonomy to be able to practice, and there's, any kind of risk factor that I see, or just, in good general health, to be able to do that preventative care and teaching. And this program allows that time and allows me the autonomy. It also means that have the time to be able to build good relationships with our patients. Those patients trust our team, and we share with them how the team members are going to interact with them or be able to help support them to that goal. And because we're staying patient focused and centered on the patient goal, I think the patient is naturally just more engaged and is more excited, basically, to get to where they want to go. They can see the small gains that they're making. Our team communicates often and transparently. We use the Teams platform to be able to keep open channels of communication going around these patients. That means that, you know, even the small things that the patient wants you to know. You know, if they have a doctor's appointment, that the entire team knows that they're going to that doctor's appointment. And even something as simple as us not trying to have a visit, you know, at the same time they're going to the doctor, eliminates some of that patient stress that they feel. But it helps them know that they're at the center of our planning, that we're not planning our day, you know, for our schedule, that we're planning our day and time around the patient needs for our clients. We have daily huddles, so anything that's urgent, any new patient coming out would be spoken about in a daily huddle. Anything that's working or not working, we talk about in daily huddle. And then we do weekly care planning, which is done with all of the interprofessional team. The huddles involve all the interprofessional team as well. So the dietitian will be on in the morning, the speech language pathologist, occupational therapy, physiotherapy, social work. So, and at our weekly care planning meetings, we review the care plans that are generated by triggers from the inter-RI. And we review the interventions that are unique to that patient and that align with the patient goal for their plan while they're on service. We send welcome letters to connect with the PCP, and we share any assessment notes that we do. So if I do a lower limb assessment, if I do an ABPI, I write that up and send that to the primary care provider. The same thing if we're doing any kind of pain assessment, to be able to let them know how the use of pain medication is going. This is often important because the patients coming out that have new pain medication are going to need a repeat, and they're going to usually need a repeat in 7 to 14 days after leaving the acute care hospital. And we need to be able to communicate to the PCP, is this medication working? You know, what other methods is the patient using? Just to be able to give them some background, which they may not always have or be able to get. And we educate and mentor each other. We discuss ideas and find solutions together. We have 2 patients on service right now that have come on in the last 14 days. And these patients were sent home from hospital. Both of them are just not strong enough yet to do the stairs in their home. And we've had to reinvent bedrooms and bathrooms facilities on the main floor, so that they're able to, you know, live safely on the main floor of their home. We talk about different things. Susan touched on this, like making sure there's a commode, for example, in a home where a patient's just not strong enough or agile enough to get up to be able to make it to the bathroom. We can order equipment and have it delivered the same day. And that's the responsibility of all the clinicians in the program. So if the PSW is in, and they are just so great with functional rehabilitation, the PSWs on our team, and they're amazing with skin care. But they often will be the first one to say, you know, I was just in there, and, you know, like Mrs. Smith just isn't able to get up off the toilet. And I think, you know, she's been holding her bladder waiting for me to get there so that she could get to the toilet. And that's a cue for us in the middle of a, you know, Friday afternoon right now to figure out how we're going to get a commode in the home to be able to solve this problem for the patient before it becomes a bigger problem or issue for Mrs. Smith. And that speaks to the advocacy. We're able to advocate for the services, for the treatment, for the equipment, and having access to an interprofessional team and having the communication among that team allows us to draw on a network of information. And we're building the resources and pathways for every patient we see. And every patient we see teaches us a little bit more about the resources and the networks that we're able to find in these communities. So as a SWAN, I usually see the patients within 3 to 5 days of joining service if they're not my patients. I mean, I see a patient and have the autonomy to do my assessments for all the patients that would be my primary, of course, on the initial visit. My colleagues, though, usually have me go in within 3 to 5 days for a patient that they've identified that has a need that might be appropriate for me. So I've seen patients that have catheters that just need some extra support in I mean, I saw a gentleman once who really was not happy to have his catheter, and the nurse had tried to explain it. And I just went in to talk to him about how his journey to getting the catheter and what his goals were with having the catheter and what he wanted his life to look like moving forward. And we had a good conversation that really the catheter wasn't the end option, that this wasn't necessarily something he would have to have forever. And that, you know, he was a very capable patient. And we actually ended up talking to his doctor about self-catheterization. I think this was a younger gentleman who, you know, wanted to have an active sex life and really felt like the catheter was impacting that. And that was his priority in his life. And I think by being able to sit down and have that conversation with him and understand his medical needs and his personal needs, we were able to communicate with the surgeon, the urologist, and he was able to change the care plan after a 2 or 3 weeks. I think they did a couple of visits, but that's where this gentleman ended up. And I think that's the purpose of our program, is to be able to make sure that we're meeting the client goals, not the goals that we've set out for them, or that are our usual interventions and goals, you know, for these patients. We discuss skin health, of course, showering and bathing. I see patients who, when they come on, as I say, they've been independent. They've never had anyone help them with a sponge bath or help them to get into the shower. They're sometimes quick to say, you know what, I can do my own sponge bath. I don't really need a shower. And it's because of that vulnerability, that they're just not ready to have someone work with them to get them, you know, to be there for safety, getting them into the shower. But again, we have the time and we have the space to be able to build those relationships, to be able to see these people progress to being able to get in the shower. I've also seen some patients who have lived alone that probably haven't, you know, weren't showering because they lost the functional ability to get into the shower safely, and they've built relationships with the PSWs. And, you know, just really honestly having those conversations about skin health and why it might be important to be able to get into the shower and, you know, get into all the creases that they're not getting, and really getting, you know, making it important to them so that they're open to these care and having support for that care. My PSWs will tell you, and they're not mine, but they know I speak about them quite affectionately. But we have a lot of jokes because the patients will make sure the lotion is out. They will tell them, you know, they will tell me when I come in that the PSW has said that the nurse was supposed to help them with the lotion today because it wasn't a PSW day, and I'm supposed to help them with their lotion. But it's being able to gain the trust of these patients, to be able to show them why these little interventions matter, and seeing them adopt these changes into their life before they get to, you know, a place where they're experiencing skin tears at home, before they ever get to maybe, you know, being in an acute care facility or in a long-term care facility. You know, we're going to improve their skin health overall for their life, because these are not things that happen as you age. They are things that we can start to do preventative interventions for now. As Susan said, I discuss with people that urinary incontinence is not a condition that comes with age. And it's not permanent when you go to the hospital. And we do hear this often, that they're wearing briefs, that they were told, you know, there's just, they have a brief on, that they could go in the brief. You know, a lot of patients talk openly about that, you know, they're concerned that they're not going to, you know, be able to go to the washroom the same, that they're always going to have to wear these briefs at home. And being able to talk to them about, you know, toileting, and being able to talk to them about hydration, being able to access the dietitian again to be able to support that is really important for these people. We assess bowel concerns, and I make recommendations. Of course, all of these things go hand in hand to working with the physiotherapist to you know, get these people up and active. That's our goal. We do active rehab. We want them to be able to do as much as they can independently. I see some ostomies very rarely, but Occasionally there'll be an ostomy that come on, and if they're a stable ostomy, I generally see them. We did though have a lady on recently who had an ostomy established 5 years ago, and somewhere in her healthcare journey, she was told that she could not get the ostomy wet, or the appliance wet. She hadn't been in the shower in 5 years. The ostomy was created in 2019. And it was in 2025, this winter, that this lady stepped into the shower for the first time, and had a wonderful shower, and has been showering ever since. I think I've already touched on, I complete lower leg assessment, ABPIs, monofilament testing. Basically, if the patient needs that assessment, then I just do it. And the transitional care, having the autonomy to be able to practice, means that when these patients, you know, have these assessments, I don't have to refer to anyone else, or I don't have to ask for specialized visits to be able to go back to be able to do the testing. I just do it in the moment. And it's often very meaningful in those moments, and the patients feel, you know, they feel cared for. They are a bit amazed. I explained to them that my bag of tricks, you know, is not every nurse's bag of tricks. They call it my little Mary Poppins carpet bag, because there seems to be everything in there. But there's a lot of things in there that are great for teaching. And I mean, patients feel like, as I say, that you've come prepared to be able to kind of tackle everything with them. I look at footwear. I make sure, you know, people are wearing good fitting slippers and shoes inside the house. We always make sure that they have something that's non-slip on their feet. We're trying to prevent a lot of falls. We, of course, have a lot of patients with high fall risks. And I have a wonderful NSWOC who I connect with to support me in collaboration, to create treatment plans, to see the more complex patients. She is able to come out and debride. And I think, I'm hopeful, you know, and well, I do know that we work really well together, but the thing is, it's given this region access to this kind of SWAN NSWOC connection care focused on wound ostomy continence. And as a SWAN, the most important thing is I'm a valued clinician in my interprofessional team. And I see you're there, Josh, which means I'm out of time, but this is the last slide.
Take your time, Sharon. I'm just letting you know I'm here.
Yes. So, but the benefits of the transition team are that patients are seen by a clinician quickly, and they receive preventative teaching and support. And then there's time for follow through, evaluation. We're able to redirect the treatment. The patients receive consistent care, and there's a unified support from the team, because our interprofessional team is communicating all the time. The messaging is the same. And so we can say to someone, you know, this is what we talked to the patient about. I've talked to them about compression, and they're willing to give it a try, but they want me to discuss it with their daughter who's there in 2 days. So please, let's reapproach it in 2 days when the daughter is there, because otherwise we're going to overwhelm them. And we you know what I mean? We're going to take it away from them being able to lead us to the care that they need. And I mean, patients report that they learn during our program. That's the thing that fills my heart. I was looking at data, and I have a lot of subjective data on my 8-week and my end of program care conferencing that I do. And it lifts my heart that they feel supported. They feel they've met their goals. They feel they've learned about their health, and they've basically become advocates for themselves. So they know, you know, the things that they're looking for and the things they can do to keep themselves healthy moving forward. I was going to say, and I will pop up my email, my little stats there. I guess my emails are not on there, but you can reach me. I'm the SWAN director, which Joshua had said, and I also just want to put out there that I'm also on the WeRPN board of directors for RPNs in Ontario.
Thank you, Sharon, for sharing your incredible and comprehensive scope of practice in the transition of care. I've learned a lot of deal with your talk this afternoon, so I really, really appreciate that. But before I provide some points on my end, I'm just going to see on the chat box if there are any questions that people would like to ask Sharon. Kindly do so. Do you have any? Okay, so I'm waiting. There's a couple of things that pops out to me. One of them specifically, Sharon, is I like how you mentioned that sometimes when nurses come into a patient's room or a client's home, their perception is that we're here to do something. Their perception is focused on the task versus focusing on the goal. So I like how you kind of switch that ideology to kind of focus that we're here not only because we want to do wound care, we want to do ostomy care, we want to do continence care. We're here to actually make you feel better, but we're here to actually, optimize the goals that you have set holistically based on a holistic assessment. And you, with your, specialization as a SWAN, you are actually able to pick up on that. And I like how the fact that you actually are patient focused and you like to partner with your clients, including their essential care providers and their families, so that they get to kind of like verbalize what's valuable for them, and at the same time also provide them education at that point in time. Now, there's one thing that stood out to me is that you mentioned about showering and the basic human necessity to shower. And sometimes it is always a misconception for frontline nurses or care provider or any care provider that if you have a wound, if you have an ostomy, you cannot shower. But you coming in on that point actually change that perception and allow the patient to actually shower, which of course although it's a basic thing to do, basic human need, you actually change and optimize the quality of life and comfort. So I really appreciate you for doing those things. You have been instrumental to your team for being autonomous, for providing and being an advocate for your clients, for the treatment interventions, for providing timely assessment and timely intervention. And your passion to kind of like be on the forefront and be at the get-go to ensure that these things are addressed immediately without having to delay actually also changes the trajectory of the patient's condition or the person's condition and prevent them from any detrimental impact as a result of delays in treatment and assessment. So I really, really like to give you that kind of like acknowledgement and about the crucial work that you do. And last but definitely not the least, I like how you kind of pull people in together with your the way that you approach people, the way that you communicate with them, at the same time the way that you see how every specific type of members of the professional team is crucial in ensuring that we provide the best optimal care and outcomes for the client. So thank you for doing that.
One last shout out for the transitional care support teams, because as I listened along today through all the presentations, and when I think about my work, Josh, what we have opportunity. We have opportunity in the fact that we have time and we have autonomy, and it makes a difference in every patient that we're able to interact with. And hopefully these are patients that we don't see again in the work that we do, focused on wound, ostomy, continence, or when we do see these patients, they're going to say, you know what, somebody told me that 10 years ago, and you already have the buy-in. We're already there with patients that believe in the care.
Thanks for that. And I think you being in a director position for SWAN, Sharon, I just can't imagine the utmost impact that you can do and changes and potential initiatives out there about the roles of SWANs and how that can be intertwined collaboratively with NSWOCs and other care providers. So thank you for that. And Anne-Marie did mention here that it also makes a huge difference by taking the time needed to assess your patients. And again, I completely agree with that. So depending on the care environment and depending on the patient ratio, that can also impact the amount of time that we see. And if the way that when we're looking at patients specifically, I mean, I personally would say that when I look at my clients in my setting, is I think about how about if I'm caring for my family? How about if I'm the person being cared for? I want to make sure that I provide the type of care that I would like to receive and at adequate time. And sometimes, even if it's just a minor wound, sometimes it takes a lot of ease from a client's level of anxiety if we spend time to really explore what their patient or person-related concerns are, and that can make a huge difference in their quality of life. So thanks for Sharon for kind of inspiring us about that and really appreciating the the value of time as we give them to our clients. Thank you. Okay, so it's 2:18. I don't see any questions in our chat box. And now we are on to our last segment of our session, and that is providing you with some updates from NSWOCC. I'm going to be turning off my video because my laptop tends to lag if I do both. So I'm just going to share my screen on my end. Please bear with me. And just a thumbs up from anybody if you can see my screen, because I won't be able to see the chat box at this time. Okay, good. Thank you for that. So now for some exciting update on the current and future initiatives from NSWOC Canada. There are two main objectives that we would like to really accomplish for the next few minutes here. One, of course, is to provide you an update on current initiatives and its progress, and also to demonstrate some sense of transparency of the NSWOC Canada initiatives. Just gonna let this thing come off. Okay, there we go. So, and this slide just highlights how the flow of funding is facilitated to support ongoing operational needs and initiatives of NSWOC Canada members. It is really important for us to highlight that we have a robust internal control process that reviews and approves funding or money that moves across the organization. Just want to let you know that our annual financial audit passed successfully. So congratulations to the team that looks after this important aspect of our organization. I just want to say that let the countdown begin, because in just less than 4 weeks from now, our 44th National Conference will take place in the beautiful city of Montreal, Quebec. Our theme, as what we have highlighted before, will be on IDEAS, which stands for inclusivity, diversity, equity, accessibility in wound, ostomy, and continence. And I'm looking at the agenda, and I was reviewing it almost recently as well, that there are lots of fresh new learnings that can be acquired from this conference, as well as plenty of opportunity to network with new and current NSWOC and SWAN and industry colleagues. And also, just want to let you know that our NSWOC annual members meeting will happen on the Thursday of May 22nd, 2025. So hopefully that you guys can meet there so we can all meet and greet at the same time. Now, the other thing that I really want you to really pay close attention to is I don't really want you to miss out on our networking event that's happening, which is focused on the theme of disco. And I think fortunately, I've been voluntold to dress up on this day to support this event. So if you have any suggestions for what costume I should wear, please let me know. But again, this is an important venue for us to really network not only with NSWOCs and SWANs, but also with our industry partners. So if you have not yet had the chance to register, kindly do so and hope to see you there. For more details, please visit our NSWOC Canada website. So just recently this month on April 10th, 2025, we have celebrated the global World Without Skin Tears Day. Unfortunately, as what you may be aware, skin tears are often a neglected breakdown and lesion and have not been shown the same level of urgency as pressure injuries or other types of complex wounds. Therefore, there is definitely a need for us to raise awareness on its timely identification and management. If you did not get a chance to attend the webinar, there is an on-demand for this event available on the ISTAP website at www.skintears.org. And you can also, for you to kind of access the on-demand, you can join ISTAP. That allows you also access to different resources available on the website. And joining is actually free of charge. So what more can we ask for? That this is going to be a learning opportunity for us, as well as a way for us to also share the advances in managing skin tears. Now, on the upcoming NSWOC conference as well, there is actually a talk by Dr. Ray Samurio on skin tears in people with different skin tones. And, you know, skin tones, its variants and differences has been a theme for us, it seems, today. So this is something that is very valuable for you to join, and it's going to happen on the Saturday of the May 24th, 2025. So again, another exciting discussion, another exciting talk that will happen at the upcoming NSWOC conference. So just recently as well, on April 14th to 18th, we have celebrated our NSWOC week. So to my fellow NSWOCs, happy belated NSWOC week, and hope that you guys have the opportunity to be acknowledged in your different practice areas. Now, I just want to also take a moment to really acknowledge the team behind this incredible design of this beautiful flyer, with its Canadian flair, with the golden standard, the golden medal, as well as the hockey jersey that goes along with it, along with our tri-specialty. So I love this design. So thank you for the people behind this for exemplifying the roles of NSWOC during this week. So after a successful first pressure injury summit that was held last November at UHN, please kindly mark on your calendars the upcoming summit that will be hosted on November 21st, 2025 on a Friday. And this will also be a hybrid event, but the in-person event will be taking place in Ottawa at the Carleton University, but we'll also have virtual access for people who cannot make on this, who could not make it in person. So as we continue to strive for changes in how we address and manage pressure injuries across our nation, we have to ensure that we involve stakeholders from various level of governance. Therefore, hosting it in Ottawa just makes sense because it definitely allows us to be an appropriate venue to engage such stakeholders within our close proximity. And again, going back to our NSWOC conference, one of our members of our NSWOC, our CPIP panel, Dr. Chester Ho and Dr. Sharon Gabison, will be doing a talk again also on Saturday towards on a title that is entitled Towards the Development of an Expert Consensus, Recommendations for Provincial and Jurisdictional Pressure Injury Policies in Canada. And from our summit, policies around pressure injury is lacking. So this is actually an important talk for us to really have and see what we can do out there to kind of push this initiative forward. So another exciting and massive event that's happening just next year in 2026 is the historic joint congress between WCET and NSWOC Canada. The congress will take place in Vancouver, British Columbia. So this joint WCET and NSWOC Congress offers a unique opportunity for nurses and industry partners from across the globe to come together, learn from one another, and engage with WCET and NSWOC Canada members and their partners. So the theme, as what you can see here, is in it together, moving mountains to create a world of better wound ostomy and continence care. So there will be a call for abstract submission in the middle of 2025. So we will keep you up to date and posted when this opens. So please, we cannot strongly reinforce and encourage you enough to please bring your work forward. The talks that we have had today are amazing and has distinctive and massive impact to patient care and health systems. So those are great things that people should know about, that people can pick up upon, that they can also apply wherever they're at in their practice areas in the world. Now, in terms of the Indigenous Echo Skin and Wound, the first session will be completed by June of 2025. And there are about 166 healthcare professionals that would have been educated on lower limb and common dermatological skin lesions and disorders among the Indigenous communities. Now, Project Echo is focused in optimizing clinical expertise and capacity in wound care to safely and effectively support the wound care needs of Ontarians. Now, at our NSWOC conference, Michelle Buffalo, along with Bev Smith, Jeremy Call, and Audrey Lafortune, on Friday, May 23rd, we'll be talking about health equity in Indigenous populations. So it's important for us to really support this talk as well on the upcoming conference. So in terms of being a charitable organization, a registered charity, NSWOC supports a lot of patient initiatives and other registered charity organizations, such as Ostomy Canada Society, where we recently were a gold sponsor for their Step Up for Ostomy event. And just want to let everybody know as well that 10% of our earnings obtained from the swag and shirts goes to the proceeds to support a camper to attend Ostomy Youth Camp. And speaking of Ostomy Youth Camp, NSWOC will donate to support a camper this year. And this year, the venue will be held in southwest of Calgary in a beautiful camping site around Bragg Creek, Alberta. So looking forward to the events and how this will have a positive impact to our youth, and looking forward to hearing from this event moving forward. So again, Sharon just talked to us, and I would like to congratulate her formally. It's this slide is here for winning the SWAN director election. So kudos to Sharon. A huge round of applause for her. She will serve as a SWAN director for the NSWOC board. So I completely support Sharon for her upcoming initiatives as she raises the flag for SWANs. And just hearing the vital role that she plays, and along as the other members of our SWAN team across different health sectors. So it will be interesting to see and pivotal for Sharon to actually work with her initiatives to have a better impact for our SWAN community as well. So thank you, Sharon, and congratulations. Now, we've been talking a lot about advocacy, from our NSWOC and SWAN colleagues. Now, as a whole, NSWOC Canada also has been in the role for advocacy, and one of them is on the new reimbursement model that's being explored related to ostomy supplies in New Brunswick. Now, NSWOC Canada has been in talks with the ministry, and a new model of reimbursement was developed. There is a part 2 of an ostomy impact study that's being established at the moment. And currently, we are working closely with Coloplast to look into an economic analysis on how this new model of care is going to be more supported and make an impact across New Brunswick. Now, more details to come as we continue to pursue this initiative. And as what you may have been aware that there has been a change in ministry. But we're going to keep on pushing forward to make sure that this happens. Now, from our last talk as well, we're also going to reinsert it here. NSWOC has advocated to have specialized process to enable patients with a cock pouch to access Medina catheters. So if you are wondering how to access them and would like more information, including a PowerPoint, a webinar, or even sample forms to guide you on how to gain access, kindly please contact office@nswoc.ca, and we are more than happy to actually assist you with the needed information that you may require. And I'm actually happy to add this slide on our update today because as what we have discussed from our last regional meeting, our peer-reviewed journal has undergone a makeover with a more scientific look. The name has been changed formally from NSWOC Advance to Canadian Journal of Wound, Ostomy, and Continence. So if you are currently looking to publish, please check the CJWOC and send your research and manuscripts for publication. They have details and guidelines on publication on the website. But I just want to take a moment to really admire the look of this with the red and black undertones, and it also highlights our official interest groups on CPIAP and ISTAP. So great work for the people behind this. It looks amazing. So looking forward to seeing more of the research and studies and great work that our Canadian NSWOCs and SWANs and communities are doing that will be manifested on the slide and be exemplified under the CJWOC publication. So from our talks today, you have heard how valuable education is. So our Wound Ostomy Continence Institute continues to expand its comprehensive academic programs. Recently, the Institute has added courses on 2S LGBTQIA+, Paramedics Practice Enrichment Series, and the PSW and Caregiver Skin Health Program. So if you know of any person interested in advancing professional development and may benefit from any of these courses, kindly share this information to your colleagues. So for more information about the programs offered by WOCC Institute, kindly visit the website at www.woccinstitute.ca/programs. Again, it's important. There are a lot of education programs out there, but we want to make sure that we have a robust program that focuses on key aspects of wound ostomy continence and aspects of care that ensures that they are well prepared, that all of us are well prepared in clinical practice. So these are the things that we highly recommend that you can, if you can kindly spread the word to amongst your colleagues and amongst your healthcare sectors and teams. Now on to some projects. In May of 2025, a new set of best practice recommendations on harm reduction in wounds will be launched. Looking forward to see how much of this needed BPR can influence our practice. And just want to let everyone know that this work is actually funded by NSWOCC. Now on our upcoming conference as well, I do believe that there is a talk behind this by, one moment, just trying to check my slide here. There's going to be a talk on the conference of the harm reduction, I think on a Friday, May 23. So again, check that out. And looking forward to how this best practice document guidelines will kind of be released and see how it actually impacts the outcomes on our care and the outcomes on patients as well. So in January of this year, the project on developing an international set of best practice recommendation for pediatric ostomy management has been launched. From what I recall from our former meeting, it was, I believe it was initially catered only for, Canadian best practice guidelines. But now this project will be co-led by Emily Woodgate of Canada and Karen Dick from the UK, making it an international BPR. So exciting to see how this unfolds as this has become an international guideline, as I've mentioned. So looking forward for more of this to come. So another new project that has been launched recently as well is this new exciting project on wound packing, sinus, tunnel, and care. So if you are a clinician like me, wonders to pack or not to pack wounds, this is something that is much needed at the moment to address any of the gray areas in practice at the moment. So the project aims to develop a consensus statements and Canadian best practice recommendation on this subject matter. So the panel has been established and there is already meetings happening underway. So more to come as this panel and committee continues to work on this important best practice recommendations. So work that is so close and dear to me is this new project for moisture-associated dermatitis, which I co-lead with Dr. Kevin Wu. I really would like to acknowledge our panel of experts who are currently involved in this project in critiquing the Canadian moisture-associated skin damage tool, which is an instrument to use for assessing and monitoring skin changes from moisture dermatitis. So the panel has also established consensus statements for the assessment of MASD, and we will be presenting this at our upcoming conference on Friday, May 23rd from 1:10 to 2 o'clock. So just putting it a plug out there, and we will be in the Westmount 6 room. So hope to see you guys there to talk more about this MSD project that we are doing and the work that the panel has done to date. So exciting stuff. So in May 2025, a project revolving the review and revision of the National Standards of Practice for NSWOCs will be launched. Alison Lashane, a colleague of mine, will be taking the lead on this important initiative. So currently, we are looking for volunteers for this important project. So if you are interested, please let us know. And there will be funding provided to ensure that this project and initiative is completed. So again, looking at how this will manifest itself in the coming months. And yeah, just exciting stuff. So some updates regarding other initiatives. So there is a webinar and presentation on the Canadian BPR and malignant continuous wounds, and is now available in the French language. So thanks to our colleagues for making this possible. The harm reduction wound ostomy continence toolkit remains in progress, and more updates to come once this toolkit has been completed. Now, the consensus document on the venous ulcer management has also received NSWOC endorsement, and it is available on the nswoc.ca website. So if you'd like to check that out, please kindly do so and learn more about these consensus documents. So I'm going to stop sharing there for the moment and just to see if there are any comments or questions that people may have. Okay, there we go. So Carly just mentioned here that if anyone has any questions about the ostomy camp or has a future camper in mind, please send her an email at carly.lindsay@ontariohealthathome.ca. So please do so. So no questions on their end. So now I'm going to continue on with my slides here. Okay, so the other thing I actually want to let people know, I think we did talk about this one before, is I'm looking to currently planning to host about 1 to 2 in-person education/networking events. Of course, there's got to be education involved because that's one of the things that I value in practice. And this will be in partnership with industry and will happen sometime possibly in the summer or early fall. So once the planning has been finalized, we will be promoting the event for our Ontario NSWOCs and SWANs to register and attend. And what I'll be doing is I'm going to look at the catchment areas of where most of our NSWOCs and SWANs will be, but there will be plenty of opportunity for us to explore other areas, but open to suggestions from our family here. So stay put as we plan and looking forward to host these events in the future. Okay, so that's it for my updates. I just flew by them. But and this brings us to the very end of our session this afternoon on this entire day. So it's an incredible day, and I feel inspired, empowered, and thank you so much for our speakers today. So I just want to take a moment to extend my gratitude to our esteemed speakers for sharing their valuable time and expertise and experiences. So namely Deborah Mings, Shannon Murphy, Lori Zozzolotto, Lee Bateman, Susan Chandler, and Sharon Hunter. I think I feel the same way as other attendees today from our NSWOC and SWAN family about how valuable the information that you have provided us. Not only did you educate us, but you also just made us not teary-eyed, but inspired to do what we do as NSWOCs and SWANs. And thank you to our industry partners as well. Once again, thanks to Mölnlycke and Convatec for partnering and sponsoring our event today. Without your help, this day would not have been possible. Special thanks as well to Kathy Harley, Troy Curtis, Zachary Abram, and Jonathan Mancor for your ongoing and tireless support of not only this event, but the MASD project and the CPIAP that I am currently involved in. So all of these will not have been possible without your help. So thank you so much, especially when I try to bug you almost every single time to make sure that everything is in line. So a huge thanks to every member of our NSWOC Canada family, our SWANs, our NSWOCs, for your valuable contributions to the lives of our specialized population and for always representing our organization. Always remember, we value each and every member of the NSWOC Canada, and thank you for all our attendees and for staying all this time. Please note that the attendees of today's event will receive a certificate of attendance and continuous learning hours that can be put towards your CNA renewal for my fellow NSWOCs. Please don't forget to email office@nswoc.ca if you have any feedback, interest, or recommendations, and even for our future sessions so that we can make it more worthwhile. And for my last slide here, we really want to hear your thoughts, right? So we would like to know what you're thinking about how we can make such events and meetings better. Kindly complete the survey after today's event. Please take some time to do that. And aside from your valuable feedback, we also want to know who from our attendees today represent both in practice and the care sector that you belong. We also want to know the tri-specialty domains that you are currently practicing in your areas of practice. And we want to know your thoughts about being part of a community of practice. And Lee Bateman has just reinforced the importance of building a community of practice. It's a way for us to establish standardization. It's a way for us to talk about challenges that limits our ability to provide exceptional level of care to our clients. So please, provide us some feedback if this is something of interest to you. So kindly complete the survey. And again, this is Joshua Moralejo, your Ontario Regional Director, wishing you a wonderful weekend. And actually, that's a wrap for today.